And the next item of business this afternoon is a debate on motion number 8155 in the name of Alex Neil on person-centred healthcare. I would be grateful if those members who wish to speak in this debate could press the request to speak buttons now. I would also remind members if they make an intervention on another member, then they need to repress the request to speak buttons. And I call on Alex Neil to speak to and move the motion. Cabinet Secretary, 14 minutes.
Thank you very much indeed, Deputy Presiding Officer. I thought it would be very useful for us to have a fairly wide-ranging debate on health and social care in Scotland, given where we are, and in particular, always approaching the time of year when the pressures on the National Health Service are always at their greatest. Can I begin by just summarising what I see as the three big strategic challenges facing the National Health Service, not just in Scotland, but indeed in other developed countries. The first and the most obvious one is the financial challenge, not just in terms of the changes and reductions in public spending overall that we have had inflicted on us, but also because costs are rising, particularly for new technology and new treatments in the National Health Service on an ongoing basis. Secondly, as the Auditor-General outlined some months ago, despite all the excellent efforts of successive governments over the last 30 or 40 years, we still have a problem of inequality of access to health in Scotland, and that's an issue we have got to address. I don't believe the health service itself can address it, but I do think we have a part to play. And then thirdly is the ageing of the population. We do know that over the next 20 years or so, the number of over 75-year-olds living in Scotland will nearly double, and indeed 1/5 of all children born in Scotland today, it is reckoned by the statisticians, will live until they're about 100 years of age. So those who prepare telegrams for King William or King George are not going to be out of a job for some time. The key issue, Presiding Officer, is how do we respond to these challenges? And I could go through, probably spend 3 or 4 hours telling the Chamber everything that we're doing in health and social care in Scotland, some of which, such as the integration agenda, the members will be well aware of, others which we are doing in terms of innovation and taking forward new ideas and new ways of doing things. Our vision for the National Health and Social Care System in Scotland is that by 2020, everybody should be able to live longer, healthier lives at home or in a homely setting. And our quality strategy delivers a high standard of healthcare through safe, effective and person-centred care. Person-centred care looks different in every setting, but fundamentally, the person-centred approach means asking not what's the matter with you, but what matters to you. Later this month, my colleague Michael Matheson, the Public Health Minister, will address the third national learning event of the Person-Centred Health and Care Collaborative. Over 500 delegates will come together to learn from each other, from service users and from world experts in delivering person-centred care, where Scotland is a leading nation. The person-centred approach benefits our dedicated staff as well as the people they care for, because they came into the healthcare service to help people, not the case in bed 7. Over the last 5 years, we have invested almost £10 million directly in community-based projects across Scotland through the Self-Management Fund. I recently visited, as indeed Mr Matheson, the Thistle Foundation in Craigmillar, for example, and both of us at different times met Brian Brown, an inspirational former soldier whose life had been wrecked by post-traumatic stress disorder. His life had been turned round by receiving the sort of person-centred care we wish to see become the norm, and he now supports others at the Thistle. And this is what he said to me: "I've learned that what I needed was to be listened to be treated as a person, not as a diagnosis, and to be supported to find my own way forward and deal with my own demons." Listening carefully to people and changing how we support them is right, but it's also necessary, as no nation can afford to continue with the model of healthcare we have pursued to date. Looking at the person is the right thing to do in totality, not just looking at a particular ailment which is giving them trouble at any particular time. We must transform our approach, Presiding Officer, and the main focus of that transformation will be a shift towards primary care. Last month in Musselburgh, I met with a group of local GPs. Their concerns were about their workload, bureaucracy and, more importantly, the length of time they get to spend with their patients, or more accurately, the length of time they don't get to spend with their patients. I, like fellow members, I'm sure, and I have this in my constituency mailbag, with letters complaining of problems with getting a GP appointment, and I'm sure other members share that experience. And there are two sides to this story. Patients and GPs want the same thing, a proper relationship with each other based on trust, local knowledge and clear communication. That's the point of view of the patient, but it's also the point of view of the doctor. I'm determined to make this the norm. Our 2020 vision sets out the urgent need for an expanded role for primary care and general practice in particular. We want to keep people healthy in the community for as long as possible, reducing health inequalities and unscheduled care. We will do everything possible to support our excellent primary care workers to deliver care freed from avoidable bureaucratic paperwork. We must further develop primary care teams, allowing them to work in partnership with patients and carers to deliver care that's much more person-centred, safe and effective. And so we intend to modernise the GP contract and to transform our approach on primary care. I want to talk about each of these in turn. Modernising the GP contract. As I said earlier, GPs and the people of Scotland want the same thing, for them to have more quality time with each other. We know that getting appointments can be an issue. We know that the 48-hour access target can cause problems, albeit well-intentioned. We have a great opportunity at this time to make things better for Scotland. Late last year, for the first time ever, we negotiated a more Scottish contract with the British Medical Association in Scotland, not for constitutional reasons, but for health reasons. This allowed us to come to a negotiated agreement that differed from that imposed on GPs by Westminster. This agreement has paved the way for a new approach, and we are currently carefully considering with the BMA in Scotland what next year's contract should look like. As part of this, I am today asking my officials to work with the BMA to undertake a review of access across all GP practices in Scotland and to develop an action plan to address any issues that arise from that review. But this is just the first stage. We need to move to a new contract for GPs to match our 2020 vision and to recognise that the direction of travel of the health service north of the border is entirely different from the direction of travel south of the border, particularly in relation to primary care and how it's organised. This will take time, but my clear ambition is for a new Scottish GP contract so that GPs get the time to do what they really need and want to do, which is work with individuals to ensure that their medical care is right for them, for their family and carers, and for their local environment. Of course, GPs are only part of primary care. We need to make sure we are developing our full approach to safe, effective and person-centred primary care. Of course.
Neil Findlay.
Just before he moves off of GPs, will he look at the issue of the appointment system with GPs? In some practices, people have to go in and take a ticket as though they're buying some sausages from the butchers and sit there all day holding their ticket until they're called. I think we have to have moved on with from that in this day and age, and will he look at that?
Cabinet Secretary.
Presiding Officer, we're already looking at it, and in fact a number of pilots have been carried out in the Midlothian area, and I believe, for example, that in one GP surgery what the patients actually preferred was not to have an appointment system at all. to go back to days gone by when they could just turn up and take the risk of having to wait half an hour or an hour. But my view is that we should absolutely look at what works best, but also leave what works best more up to local decision-making and not have it centrally imposed through targets or otherwise by the Cabinet Secretary for Health. Let me turn now to primary care modernisation. Across our health and social care system, there are many great examples of innovation and improvement which are really delivering for the local area. I've heard of examples from inner-city Glasgow to rural Aberdeenshire, from the Isle of Arran to suburban Edinburgh. And all of these suggest new ways of working and new models of care. For example, the Deep End practices, ably led by Professor Graham Watt. This group represents 100 practices working in Scotland's poorest communities. Their approach is genuinely bottom-up and demonstrates some of the very real health inequality challenges facing our most deprived populations, along with suggestions as to how we must begin to address them. And from Buckhaven, I've heard about an initiative based on the Alaskan NUCA model of care. This model puts the needs of the community at the heart of the healthcare system and assists both in finding solutions to seemingly intractable health care challenges. There are a number of initiatives like the Alaskan model, such as patient access, productive general practice and managing patient flow, which show that the solution lies in primary and social care teams focusing on the needs of the people they support. This is challenging for us, but it is at the heart of our moves towards health and social care integration and the legislation we're bringing forward to make that happen. To make this a reality, we need to understand what works and why it works and how it works. We must invest in developing new models of care and ensure that we're spreading the learning of this approach far and wide. That's why today I'm announcing a modernisation programme to support innovation and best practice in primary care. And I'm delighted also to announce that in year one there will be pump priming for piloting the new developments of £1 million to help move this agenda forward, along, of course, with the massive resources we already have in primary care. The first stage of this modernisation will be in commissioning strategic assessments of primary care from each of our health boards as part of their normal planning process. This will be a modernisation programme that truly delivers change. This transformation of primary care needs to be delivered in partnership across health and social care. The mutual NHS model we have here in Scotland is the right one for delivering safe, effective and person-centred care. There is a sharp contrast between our approach, based on the founding principles of being free at the point of care, while privatisation in England is growing ever more pronounced and damaging. We've abolished prescription charges while in England they remain, leaving some people in low incomes forced to choose which of their prescribed medicines they can afford. We have legislated to ensure there is no privatisation of GP services in Scotland, and we have banned the privatisation of cleaning contracts, supported by over £23 million additional resources since 2009 to pay for the hundreds of additional cleaning staff who keep our hospitals safe. Free personal and nursing care, which patients in England are not entitled to, currently improves the lives of over 77,000 older, vulnerable people in Scotland. These are achievements this Parliament, not just this Government, this Parliament can be proud of. So in conclusion, Presiding Officer, this afternoon, in setting out our ambitious approach to person-centred care, safe care and effective care, and announced a clear direction for the transformation of primary care to match our 2020 vision, and noting the differences, the increasing divergence between what happens north and south of the border, I hope that everybody in this Parliament will agree that this is the right way forward. I began by outlining the serious strategic challenges facing the health and social care services in Scotland. We need to create a health and social care system that is fit for purpose in the 21st century, and that is why we are taking forward our 2020 vision. And my ambition isn't just to have the safest health service in the world, which according to the world-leading expert we already have, Presiding Officer, my ambition is that the Scottish people will have the best health service in the world by 2020. Thank you.
Cabinet Secretary, could I ask you to move the motion, please?
Move the motion.
Many thanks. I now call on Neil Findlay to speak to and move Amendment 8155.1 with around 10 minutes. Mr Findlay.
Thanks, Presiding Officer. And can I begin by declaring an interest, as both my wife and daughter work in the NHS. Let me say from the outset that Scottish Labour shares and supports the good intentions of the Government motion. Person-centred healthcare, as it says on the tin, puts the patient at the heart of their own healthcare. Patients should, of course, be centrally involved in all key decisions affecting their journey through the treatment pathway. So the text of the Government motion stressing these points has indeed got our support. And of course, it's not just in this area where we agree with the Government. In their 2020 vision, the Scottish Government state how they are committed to the values of the NHS. The NHS created by that great post-war Labour Government, timeless values of solidarity and cooperation and the collective sharing and pooling of resources with a system based on need, not the ability to pay. I am absolutely delighted that the Scottish Government shares those Labour values, and I am glad that the Scottish Government opposes the marketisation of the NHS and expresses its support for continued investment in the public rather than the private sector. I welcome the Cabinet Secretary's rejection of the disastrous so-called reforms being introduced by the Coalition in England. Presiding Officer, what is happening in Scotland's NHS is thankfully different to what is going on in England, but the Cabinet Secretary should not use Tory ideology and an attack on the NHS there as a diversionary tactic to cover up what is happening here and now under his watch. The Presiding Officer, health policy, funding decisions and clinical priorities should always have patients at the centre. All decisions should be considered on the basis of how they will impact on the patient. I am sure that all members of this Parliament agree with that. However, there are many areas of current policy where this approach is either missing completely or is very much an afterthought. For months now, policymakers, professional bodies and trade unions have been raising the issue of how prepared the NHS is for winter. Such preparation is key to delivering person-centred care, particularly at the most testing time of the year. Last year, we saw accident and emergency units full to bursting, patients stuck in trolleys for hours on end because bed and staff numbers had been cut. 1,000 beds lost out the system since 2007, 1,200 fewer nursing and midwifery posts since 2009. How would the patients affected by these cuts view our warm words about person-centred care? Doctors and nurses complain of having to look after increasing numbers of patients without the support they need. How would the patient who hasn't seen a doctor all day because of the pressures they are under view the warm words about person-centred care? And what about the repeated boarding out of patients during their stay because of pressures? Staff tell me about patients being moved time and time again from ward to ward to try and free up space. And who could forget the appalling story last winter, exposed by the Daily Record, the story of John McGarrity, a frail 84-year-old, left for 8 hours in a hospital trolley without even a pillow after being rushed to hospital with chest pains. And John wasn't the only patient to be left on a trolley in a scene his son described to me as like a scene from a third world country, not something you would expect to see in Scotland. How would John and his family view their experience of person-centred healthcare? And of course, certainly.
Mark MacDonald.
I take on board what the member is saying, and as the member will know, there have always been and will always be individual examples of people whose care does not meet the high standards we expect. But would he accept that the Inpatient Experience Survey 2012 showed 93% of patients responding that they were treated with care and 92% responding that they were treated with respect?
Neil Findlay.
That may be the case from a survey, but I tend to rather speak to people on a day-to-day basis who come to my surgery, email me and talk to me, and I'm sure that my experience is the same with members across the Parliament, irrespective of which party they're in. Of course, we have A&E waiting times, targets missed for 4 years, then the targets changed to try and help the Government to meet them. The goalposts moved in the middle of the match. How does this sleight of hand fit in with person-centred healthcare? And the Cabinet Secretary mentioned GP practices. Some practices where patients can't get an appointment, where staffing is stretched and where GPs who want to spend more time with patients with complex needs are unable to do so. Presiding Officer, it's these areas and the general state of the nation in Scotland's NHS that should be debated. The people of Scotland, the patients and their families and the staff working, I would say heroically under enormous and growing pressure, would I suspect prefer us to consider the nuts and bolts and day-to-day realities of the world as they face it, rather than the woolly but worthy motion presented today. In such a debate, we could hear from the Government in basic questions like, do we have enough staff? Are they in the right places? How many patients should doctors be expected to look after? Is the level of financing right? How do we develop a long-term approach? What level of care do we as a nation want to see? Fundamental questions. And these have been highlighted very ably by the Herald in its NHS campaign, a campaign that reflects the concerns raised by people in our communities and in our mailbag day in, day out. Presiding Officer, one consultant I spoke to very recently summed it up when she said, if I can appeal to you to raise one thing with the Government, it's the need to end crisis management in the NHS. At present, we lurch from one crisis to another. We cannot go on like this. I therefore ask, how does person-centred healthcare sit with the view from this person's frontline post in the NHS? And we as a society owe the vast majority of staff working in the NHS and other care services a huge debt of thanks for the tireless and unstinting efforts they put in to ensure the NHS continues to function and look after us. But the reality is they are being asked to do this whilst the Government makes decisions that make their lives much more difficult. Not only are they being asked to do more with less, but the very people expected to deliver person-centred care, the person-centred care that we all aspire to, have seen their incomes cut as wages stagnate. And I have to ask, what kind of message did it send out to them when the Cabinet Secretary awarded a miserly 1% pay increase to the lowest paid staff while giving a 4% rise to senior managers? Is this redistribution Alex Neil style? So how will the healthcare system support people this winter? Will the Cabinet Secretary give us a sign of his confidence in winter planning by guaranteeing that the waiting times will be met? Will he guarantee that? I'm happy to give way to the Cabinet Secretary if he wants to intervene. I see he doesn't take that opportunity. That is maybe telling, Presiding Officer. Presiding Officer, the Government itself states in its 2020 vision how there are economic challenges ahead. These economic challenges are undoubtedly having an impact on healthcare across the board. Scotland's Auditor General expressed these concerns when he put the NHS on a financial amber warning. Last year, he gave it an amber warning and raised similar concerns about long-term financial planning this year. Audit Scotland noted how in 2012-13 pressures increased and the focus is all too often on short-term measures. A senior nurse speaking to the media said how they remembered the worst years of the Thatcher government when hospitals were desperately underfunded and, in her words, said, we are definitely getting back to that now. And, Presiding Officer, what about the critical role of social care and person-centred healthcare? As a society, not just as a parliament, we have to address the morality of a system that has been driven down to the lowest common denominator by cuts on local government. At the moment, we have a system where care providers compete for ever-squeezed contracts, where care staff are often paid at the lowest level, contracts cut to the bone, followed by wages at sometimes below the minimum wage, 15-minute care slots whether the person needs more or not, elderly people put to bed at 6 o'clock because that is when the care time slot is. Where is the person-centred approach in that? And what is happening in social care in the community is being repeated in the care home sector. What is going on in social care is grossly unfair on the councils and the good providers doing their best within a very much reducing budget, immoral for the staff involved and inhumane for the elderly and vulnerable people who need the person-centred care we all aspire to. So, Presiding Officer, we support the principle of person-centred care. Healthcare has to be built around the individual, but I fear this winter will be one of the most difficult yet for the NHS in Scotland, and unfortunately it will be the staff and, most importantly, the patients who will suffer.
Could I ask you to move your amendment officially, Mr Findlay?
Move the amendment.
Many thanks. And I now call on Jim Hume to speak to and move amendment 8155.2. Mr Hume, you have around 7 minutes.
Thank you, Deputy Presiding Officer. I too welcome the opportunity to participate in this afternoon's wide-ranging debate. In 2010, when the Deputy First Minister introduced the Patients' Rights Scotland Bill to this Parliament, she stated that patients should be at the heart of everything the health service does. And I don't think there's anybody in this chamber that would disagree with such a statement. I do welcome today's debate and the Scottish Government's confirmation that it retains this central tenet in its delivery of healthcare in Scotland. Indeed, it's one of the key principles of the 2020 vision for Scotland's NHS, which does state that whatever the setting, care will be provided to the highest standards of quality and safety, with the person at the centre of all decisions. But the Royal College of Nursing has highlighted that it can be difficult to sustain such a model of healthcare when demands upon the NHS are increasing and pressures on certain services, such as accident and emergency, for example, continue to grow. Coupled with an overstretched workforce, the Royal College of Nursing can be forgiven when they actually state all of these factors can contribute to inconsistent care that is focused on the delivery of care itself rather than the individual needs of the patient. And the evidence does back them up, and even the Minister does admit that we still have some way to go. The most recent NHS workforce statistics from ISD Scotland shows that in June there were 221.9 whole-time equivalent consultant vacancies, double that of 2 years ago, and the highest level vacancies that have been reached under this government. This situation... Yes, I may...
Cabinet Secretary.
For taking an intervention, can I explain to the member one of the reasons why there are so many more vacancies is because there are so many more jobs, because we've doubled the number of consultants since we came to power. Jim Hume.
I'm grateful for that, but the situation is worse with nurses and midwives. In June there were 1,672.9 whole-time equivalent vacancies. The number of vacancies has more than doubled in 18 months and increased by around 650 in just a year. While I'm on the subject of consultant vacancies, we can't forget last winter when the crisis in Scotland's accident and emergency departments left hundreds waiting over 12 hours for treatment. I presume delivering person-centred health care wasn't at the forefront of the minds of hard-working staff who had to catch up and deal with that situation last December and January. In response to this, members will recall the production of various action plans and promises of additional frontline staff in February. This crystallised into the promise of 18 consultants in June who were to be recruited immediately. However, when I questioned the Cabinet Secretary last month on whether these consultants were in post, he was only able to inform me of 3 at that stage having been recruited by NHS Greater Glasgow and Clyde. Following inquiries from the press, the Government press team hastily declared that the figure was actually 13 consultants now in post. So I'm not sure why the Cabinet Secretary wasn't then unable to give me an accurate answer a few hours earlier, even after 8 days advance warning. It's a little unclear, but I'm glad the possibility of negative headlines were managed to concentrate those in Government. Perhaps the Cabinet Secretary will be able to clarify later whether we do now have the promised 18 consultants. Staffing is not the only critical component to deliver this. Infrastructure and resources are too. Across the country there are regional discrepancies in treatment times for various conditions. One board may perform well in providing access to clinical psychologists in a timely fashion, but be found wanting in scheduling appointments for cardiologists. Nowhere, I think, is this better demonstrated in the ability of the various boards to meet the 62-day treatment time guarantees across all 10 cancer types. The 95% national standard is only achieved in 4 out of 10 cancer types, but the difference in timely treatment in different boards is quite alarming. For example, the most recent data highlights only 66% of colorectal cancer patients are treated on time in Grampian, 72.7% in the Borders, In Tayside, only 71.4% of melanoma patients are treated on time, with the figure reaching 75% in Fife and Grampian. With cervical cancer, it's 75% of patients in Lanarkshire, 80% in Fife and 83.3% in Lothian. And only 60% of patients with ovarian cancer in NHS Highland were treated on time. The reality is that as well-intentioned and as desirable a model as person-centred healthcare is, the raw materials need to be in place for their individual treatment pathways to be tailored to their requirements and values. With what uses a person-centred model of healthcare, if the resources aren't in place to cater for it and the staff are not in a position to deliver it, either in terms of workforce or by having too many demands on the time. Presiding Officer, I will go into deeper detail regarding the mental health part of my amendment in my later speech today, and hope that others pick up the importance of my amendment. But suffice to say that mental health is the basis of good health in Scotland. We still do have stigmas attached to mental health and illnesses, and although we have come a long way, there is still some way to go in Scotland regarding access to psychological therapies, art therapies and the like. We still have to make further progress. And, Presiding Officer, we shall be supporting the Government's motion and, of course, the Labour motion too, and I move the amendment in my name.
Many thanks. And I now call on Nanette Milne with around 7 minutes.
Thank you, Deputy Presiding Officer. Despite parts of the last two speeches, I think that this debate, and I hope this debate, is likely to be another fairly consensual one on health, because none of us can deny the importance of person-centred healthcare in achieving the best possible health outcomes for people using the NHS. Hopefully long gone are the days when patients were told what was best for them, when hospital consultants stood at their beds and discussed their condition with a retinue of staff and medical students, as I'm sure my colleague Richard Simpson will remember, and very good to see you back in the chamber, with scant reference to the patients themselves and in language that was almost impossible for a layperson to understand. In the days of yore, when I was a practising anaesthetist, I used to see my patients after the ward round, and I usually had to explain to them in simple language what lay ahead, because they'd completely failed to pick this up from the preceding discussion around their bed. There was little, if any, patient participation in discussing possible treatment options, and patients just assumed that the doctors knew best, and they were passive recipients of their care. So it's obviously right that these days are behind us, and that patients themselves are involved in decision-making about their health. But this, of course, means that they must become active partners in their own care, such as self-managing their long-term conditions and adjusting their lifestyle to avoid the complications of obesity, high blood pressure and other common features of the modern Western world. But to achieve this, and to be able to maintain a good quality of life for as long as possible, and nowadays often into extreme old age, they require support from a health and social care system which is focused on their needs rather than those of the care providers, whether that's in the community or in hospital. And that requires a well-trained, well-resourced workforce at all levels and in all parts of Scotland, which is difficult to achieve when the needs of an ageing population are growing year by year and enormous pressures are being put on restricted financial budgets. Much has been done recently and is being done to try and improve the patient experience and to put people at the heart of healthcare planning. And there is currently a plethora of patient-centred programmes within the NHS, such as Scotland's Patient Experience Programme Better Together, Living and Dying Wells, the Long-Term Conditions Alliance, the Supporting Self-Management Practice Toolkit and several others. The recent legislation on social care self-directed support and the Public Bodies Joint Working Scotland Bill currently going through Parliament have a clear focus on patient well-being, aiming to improve person-centred care and to remove the barriers to accessing services by the better integration of health and social care. The thrust of all these policies is indisputably right, but there's still an enormous way to go to achieve their aims, principally by changing attitudes and cultures. Only last weekend, I encountered two anecdotal instances of unhappiness with the way older people were being dealt with. One, a 90-year-old man whose care at home fell short of expectation because his carers were very young and inexperienced and working against pressures of time. The other, an elderly lady whose family had to be very assertive with staff to prevent their mother being moved from ward to ward during a short hospital stay and then being discharged before proper home care was in place, even being told she couldn't have a Zimmer at home until she was formally assessed by social work. Such anecdotal stories abound in the NHS, and whilst overall our NH staff do a fantastic job, the pressures on the system and inadequate staff numbers can result in failures to achieve the best outcomes for the people on the receiving end of care. For those at the end of life, I'd like to support Marie Curie's efforts to have NHS Scotland carry out a national survey of the bereaved, as has been done in England, to examine all aspects of end-of-life care, including quality of care, place of death, respect and dignity, and personal preferences. If this was done, and the results acted upon, I think it would help to assure care focused on what people really want, truly person-centred end-of-life care. With regard to primary care and the accessibility to patients of GP services, I am very pleased that the Cabinet Secretary is taking this matter so seriously and looking at what can be done to improve accessibility by working with the profession to see how bureaucracy can be reduced for GPs, giving them more time to focus on their patients. I know...
Dr Simpson.
The member is aware of the fact that the guidance issued on the QOF, the Quality Outcomes Framework, in May, 1 month after it came in, ran to 224 pages.
Nanette Mill.
I confess that I was not aware of that. That's interesting information, thank you. I know when my husband did GP locums after he retired from full-time practice, the joy for him was that he could do what he was trained for and concentrate on patients, untrammelled by the form filling and the admin issues which had beset him as the senior partner in his practice. I was happy in 2004 to support the new GP contract at that time, which removed responsibility for out-of-hours care from GPs, because at that time it was becoming very difficult to recruit new entrants into primary care because they weren't prepared to do the on-call work done by their predecessors without extra payment. And now, of course, we're all used to having to go through NHS 24 to access out-of-hours medical care. That's all very well after 6 o'clock in the evening and at weekends. But I'm very concerned, and this is a personal concern, that many practices now close down at lunchtime on Wednesdays so they can concentrate on staff training, and for several days at a time over public holidays such as Christmas and New Year, when previously training was done out of hours and staff shared the holiday duties on a rota basis. Whilst I think NHS 24 by and large cover these periods well, the new system has certainly not improved patients' accessibility to their GP. I applaud the Cabinet Secretary for giving encouragement to general practices to improve access, for instance by extending the opening hours, by offering early morning and evening appointments, and by working with GPs and health boards to ensure that practices across the country will have an online repeat prescription facility. Personally, I'd also like to see more specialist nurses deployed in primary care, because they can do so much to help patients keep well within the community, so avoiding repeated hospital admissions, and also freeing up GPs to give more of their time to patients who need their expertise. So I look forward to the outcome of the Cabinet Secretary's negotiations on a new Scottish GP contract and to the rollout of best practice across the country as a result of his modernisation agenda. To conclude, Presiding Officer, and as I said before, much good work is being done to improve the patient experience by putting them at the heart of healthcare planning, but we are still at the early stages of achieving the desired outcome. We will be supporting both amendments at decision time. Thank you.
Many thanks. Before we move to the open debate, can I remind members at this stage of the debate that those who participate must be in the chamber for closing speeches at the end of the debate? And can I also remind the chamber that business timings on a Tuesday are fluid. The debate start times are dependent on the number of topical questions both submitted and chosen by the Presiding Officer and the supplementary requests received on the day. Members should therefore be in the chamber for the start of business, since those who are late run the risk of not being called to speak in oversubscribed debates. This afternoon, however, we have time in hand, so open debate speeches are going to be of up to 7 minutes, and I call Bob Doris to be followed by Siobhan McMahon.
Thank you, Presiding Officer. I'm delighted to speak in today's debate on person-centred care. As Deputy Convener of the Health and Sport Committee, I meet often with stakeholder groups in health and social care, be it doctors or nurses groups, allied health professionals, pharmaceutical companies, pharmacists, social workers, addiction workers, occupational therapists. I could go on, but don't worry, Presiding Officer, I won't. The reason I'm mentioning the list of groups is all these stakeholders, I'm sure, has the patient, as their primary concern. However, every group also has a very specific interest and a very specific point of view, and that can sometimes contrast and be different from other stakeholders. However, what person-centred healthcare should embody and person-centred social care should embody is the interests of each individual stakeholder, vested interests, if you like, Presiding Officer, and I mean that kindly, not in a negative sense, should be seen as secondary to the needs of the constituent, the people we represent, the service user. And progress has been made. For instance, GP surgeries do now open for longer, and they do open under more flexible hours. And it is now easier, and I have listened to some of the concerns raised, it is now easier in many cases to see a GP than it was previously, and that has been a positive change. And I am pleased that the heat target introduced in 2007 to ensure that all patients going to see an appropriate member of the GP practice team within 48 hours has been met in almost every health board. I think 5 just missed out, and that's over 90% of patients getting that 48-hour target. But no complacency, because targets only tell part of the story, which is why I'm delighted the Cabinet Secretary for Health has looked to see if there's unintended consequences from that 48-hour target, and to look more imaginatively at how we can use the GP contract to better meet the needs of our constituents. And I think one thing I would say in relation to that is I also took part in the Keys to Life debate on learning disabilities, and I know the Scottish Government is actively looking at perhaps having a QOF indicator there in relation to those with learning disabilities and the special attention they may need and the special support they may need from GPs when they go along to see their doctor. So I welcome that, but it's not just GPs, of course, Presiding Officer, but maybe health centres more generally should look at services beyond 9 to 5 or 5 days a week. Why would we single out GPs? There's associated support services that have to be in the health centre. If you have to see a community nurse after you see your doctor, does it not make sense to have community nurses on a Saturday morning if GPs are also working a Saturday morning, say, in a health centre? So we have to think more imaginatively at how we can use the overall resource. And I'm delighted to know that there are discussions ongoing and how we can do that. I'm also encouraged that the Scottish Government has established a person-centred health and social care collaborative, and that its third meeting will be held shortly. The 500 stakeholders, I'm sure, will look at how services can be developed in the long term. I did look at the remit of it, and I was delighted to see that one of the aspects of the remit was to focus on what we can do now, because sometimes when these things are set up, it's manana, it's 2 years, 3 years, 4 years. So actively they're looking to see what can happen in the months and the years ahead in the short term, not just the long term, as important, of course, as long-term planning is. I also welcome the £4 million the Scottish Government is giving to 5 health boards, including my own area, Greater Glasgow and Clyde. The money is to look at innovative ways of delivering a 7-day health service provision and enhancing around-the-clock care. If I could give just maybe 2 examples of that, and like Mr Findlay, perhaps I should declare a slight interest. My wife is a nurse in a high dependency unit in Glasgow, and she's worked in a variety of capacities in surgical nursing. If someone's ready for dismissal but you can't get hold of the pharmacist because the pharmacy is closed, that can lead to a delayed discharge. Or if the physiotherapist has to tend to a patient to make sure that they're fit and capable and able to go home and they can use any support equipment given appropriately and safely, then they can't go home if the physiotherapist isn't around. So we have to look more imaginatively at when different health professionals are actually on ward, on call, in hospital, in the health centre and around, and that £4 million can help hopefully think of some good ideas in relation to do that. I am pleased that the Scottish Government is looking at making not just health but also social care more person-centred, and maybe just say a little bit about self-directed support and how liberating that can be for individuals. Self-directed support has had some negative press, not because of the principles of self-directed support itself, but because of a number of local authorities perhaps using it as a cost-cutting exercise rather than actually adhering to the principles of self-directed support. and it's only reasonable that I do mention my own local authority of Glasgow, and in particular how they have treated those with learning disabilities on the day centre reforms and closures within the city. I'm minded that in a briefing for this debate, the Health and Social Care Alliance has said that there should be shared decision-making when changes happen. Well, there was no shared decision-making in Glasgow in relation to learning disabled individuals and their families who were just told their centres will be closing. That goes completely against the principles of person-centred care, and it goes completely against the principles of self-directed support. The Learning Disability Alliance also said, when you're designing services, nothing about us without us, and that simply wasn't the case in Glasgow. Can I thank the Cabinet Secretary for making an offer to Glasgow City Council to think again at their proposals to close 3 day centres within the city and to work in partnership with Glasgow City Council. And I'm very disappointed they seem to have snubbed that offer, but we live to fight another day on that one. Back to the positive aspects of person-centred care, and can I perhaps mention that some good work that already does actually happen, Presiding Officer. For example, if you look at those with MS, Revive MS in Glasgow already offers very person-centred care, not just for those with MS but also their families and how they support them. And it's always work in progress. For example, a constituent, Mr James Jamieson, contacted me about the need to support those living with hydrantitis, a brutal skin condition, I have to say, and about how we can improve care needs with that. And I'm in correspondence with the Cabinet Secretary to seek to improve that. So a lot of good things happening as well, Presiding Officer. I'll just finish off by saying that with a £300 million already spent in change fund monies across Scotland in terms of helping older people, in terms of £100 million on the table for an integration fund with health and social care integration, I'm really excited about the opportunities that sit ahead, but I'm also minded that we have to scrutinise the changes that we do make to make sure we actually deliver what we say we want to deliver, and that is truly 24/7 health and social care that meets the needs of my constituents and constituents right across the country.
Many thanks. I now call Siobhan McMahon to be followed by Aileen MacLeod.
Thank you. Last week, I and a number of colleagues from Lanarkshire met with Healthcare Improvement Scotland's review team. During what I thought was a productive meeting, the topic of patient-centred healthcare was a recurring theme. Many of the difficulties and concerns that members raised with the team were solely about putting the patient first. I raise my own concerns regarding this, as I feel that we're letting patients and staff down because we're not giving them the resources to be able to deliver the vision we would all like to see. I'm not solely talking about financial resources, but sometimes what is required is a clear vision from government to those who are delivering the promises on the ground. Far too often this link is missing, which then leads to one part blaming the other part, resulting in the patient being left in the middle. I understand that staff in our health services are under extreme pressure at present. That is something that I would like to see addressed in any proposed bill, is rather than adding more to the workload of staff, we should be trying to reduce the burden being placed on them. As a result of these pressures, the little things are sometimes missed, like actually listening to what a patient is telling them, rather than hearing what they think the patient is telling them. I'm currently helping a gentleman who went to his GP in June of this year with what he thought was a urine infection. The GP prescribed him medicine for a 7-day dose, despite my constituent informing the GP that he was prone to these types of infections and that a 7-day dose had never worked for him. Obviously, the GP dismissed these concerns and sent the man on his way. He completed the medicine, the infection returned, and he appeared back at his GP for more medication. Had the GP actually listened to his patient and listened to his experiences, that may not have happened, and what was to follow may not have happened. My constituent was referred to a urologist at Hairmyres Hospital in October. His appointment date was delayed for the original date, during which time he had to go back to his GP for yet more medication, as the infection was still persisting. He attended the clinic on the 7th of October and had various tests done. However, he was referred to for further tests and was told an appointment would be forthcoming. When his appointment arrived, it wasn't for Hairmyres, as he was expecting, but the Golden Jubilee. He attended the appointment and had further tests done. My constituent still has the symptoms he presented himself with to his GP in June of this year, and yet 5 months on, he has yet to receive a diagnosis. I wonder if the vision that the government has for patient-centred healthcare will actually make a difference to people in situations like this, or will it be something politicians speak of as an ideal rather than a reality? The Equal Opportunities Committee recently heard evidence from a number of disability organisations regarding the Scottish Government's proposed budget. During evidence, there was a discussion regarding self-directed support, as Bob Doris has touched on in his speech. What was clear was that everyone supports the idea of SDS. However, how this will work in practice is causing a great deal of concern and confusion. We heard from Pam Duncan of Independent Living in Scotland about her experiences of SDS. Pam said, "I consider myself to be a particularly resilient person, but I went through the personalisation process very recently, and I can honestly say that it is just about broke me. It was the most demoralising, inhumane and degrading experiences that I've ever had. However, I have come out of it at the other end, still believing that self-directed support is absolutely the way to deliver social care. Self-directed support delivers choice, control, freedom and dignity in a way that the disability movement has campaigned for many years. But it does that only at the end point when you get the budget, rather than at the point when you get your assessment or become eligible for support." Further to this, the Glasgow Centre for Inclusive Living said, "There is no doubt that self-directed support is a good thing for disabled people. Where it works well, self-directed support is fantastically empowering, but that can be totally overridden by the lack of availability of funds. I think that the situation has become so serious that we need to take a long, hard look at how we fund social care." As I mentioned earlier, SDS was about giving individuals the choice to have a care package suitable for their needs. This was a vision shared by the majority across this chamber. I know that it's in very early days in the process, but we are already hearing of the difficulties that people are experiencing when trying to access this service. If a patient-centred healthcare system is to work, then we have to learn the lessons from other similar policy initiatives. Therefore, I would ask the Government to look closely at how SDS is being implemented across our country and to learn the lessons from it. A number of organisations sent us briefings for this afternoon's debate, and I am thankful to them for that. However, Inclusion Scotland's briefing caught my attention in particular. Inclusion Scotland have welcomed the move towards person-centred care. However, they are concerned that this approach remains focused on the management of conditions and not on the wider needs of the person, such as access issues, how they are treated by others, and support for independent living. Further to this, they state that disabled people have a real concern that, as presently worded, the Public Bodies Joint Work in Scotland Bill may facilitate a move back towards the medical model of care rather than the development of a human rights-based social model of care. It is essential that in any policy developed to obtain a person-centred healthcare, that we do more than adopt the social model of disability, but that it is implemented at every stage of the healthcare system. If we are to go back to the medical model of disability, then we will undermine the proposal's approach at the very beginning. The Cabinet Secretary mentioned in his opening remarks about primary care services and how they should be tailored to the area that we come from, and the Cabinet Secretary will be aware that a one-size-all doesn't fit everyone, given that the Douglas Street practice in Hamilton hasn't fit in with everyone there. And again, I listened to his remarks and I welcome the additional money that he proposed for the fund that he announced. However, I would ask him to specifically look at what patients are telling us in those local areas. It's not simply enough to say that Lanarkshire works, with different aspects, as I'm sure he's aware, in Lanarkshire, and to review things that aren't working for patients and individuals if we're really serious about talking about person-centred healthcare, because it's not working for the people of Hamilton at that precise moment. I welcome the principle of the Government's motion today. However, as I said at the beginning of my speech, if the vision is to be achieved, the Government will need to provide all the resources required, financial, educational, training and leadership resources, for the policy to be achieved and for it to be a success for each individual person we represent. This policy should be about everyone, regardless of their needs. I hope that that is something that can be delivered. Thank you.
Thank you very much. I now call Aileen MacLeod to be followed by George Adam.
Thank you, Presiding Officer, and I welcome the opportunity to speak in this afternoon's debate on what is a fundamental principle in the delivery of safe, effective and world-class care for the people of Scotland, that health and social care services are firmly integrated around the needs of individuals, their carers and families, placing people at the centre and ensuring that they have the support to direct their own care. And I'd also like to start by thanking the Alliance, the RCN, Marie Curie, Macmillan Cancer and Inclusion Scotland for their very helpful briefings in advance of today's debate. Now, as the Cabinet Secretary has outlined, the principle of person-centred care is one of the 3 quality ambitions in the 2010 Healthcare Quality Strategy, which itself reflects the priorities of the 2020 vision of Scotland as a country in which people live longer, healthier lives at home or in a homely setting. Now, last week, Presiding Officer, I attended an event in the Parliament with allied health professionals where I met a young disabled woman called Emma, who lives independently but relies on care. And she called good quality person-centred care her passport to life. And I think that says in a nutshell what it is that we're trying to achieve and why. So a key consideration in making NHS services truly person-centred is how we provide them in ways that suit the needs of individual patients and what matters to them. And as the Cabinet Secretary has said previously, this does not mean like routine operations taking place at midnight, but it certainly should mean that a patient who is ready to be discharged from a hospital on a Saturday morning doesn't wait until the Monday because the right mix of integrated services isn't available over the weekend. And that's why, like my colleague Bob Doris, I welcome the £4 million that the Scottish Government is investing across the 5 health boards, the Borders, Lanarkshire, Forth Valley, Tayside, Greater Glasgow and Clyde, to trial innovative approaches within acute care to ensure that Scotland's NHS is a genuinely 7-day service. Of course, this in turn will require a transformative shift in approach within primary and community health care to ensure that our GPs have the necessary time, capacity and support for delivering person-centred, safe and effective care locally, and which enable people to have greater access to GP and other practice services. So partnership working with patients themselves, their families and carers, the third sector, the allied health professionals, community nurses, pharmacists, social care providers will be key, and this is central to the whole health and social care integration agenda. Now, Presiding Officer, there are a number of innovative projects focusing on new models of care delivery and new forms of partnership with GPs that are worth highlighting. Now, for example, there is a Health and Social Care Alliance in partnership with the Royal College of General Practitioners has been taking forward an 18-month pilot project called Improving Links in Primary Care. And this is funded by the Scottish Government, and it used 4 pilot sites to explore how the providers of support, such as the statutory and third sectors, can be integrated for mutual benefit, and what the benefits are of strengthening connections between general practice and local communities, whether it be signposting people to local services. And it also tested the feasibility of embedding the ALICE system, a local information system for Scotland, in general practices, which is essentially a bottom-up approach that connects existing online resources, making it possible for people and local organisations who know best to access and share local information. And this shows, Presiding Officer, what can be done. Another example is that of the deep end GP practices, where there are some very serious challenges facing many of our GPs working in areas of multiple deprivation and health inequalities, and how they deal with the increasing number of patients requiring more complex long-term health care, of course, all of which are being exacerbated by our welfare reform changes. Now, through the assistance of Professor Graham Watt, I met recently with a number of members of the Deep End group of GPs who work in some of the most deprived communities in Scotland, and they want to tackle head-on what they call the dark synergy of factors that generate health inequalities. And they argue that the population-based distribution of GPs does not match the demands and needs of the most deprived communities and the challenges of lower life expectancy, higher incidences of serious long-term conditions and comorbidities. Now, their vision, Presiding Officer, affords GPs at the deep end the time and resources to start tackling the effects of deep-seated societal issues on patient health and to turn GP surgeries into integrated healthcare hubs for the provision of a variety of interdisciplinary care and support services, with social workers attached to general practice and the link worker role connecting practices and patients to community resources for health. Presiding Officer, it's with these examples in mind that I welcome the Cabinet Secretary's announcement today for an initial £1 million development fund as part of a modernisation programme to support innovation and best practice in primary care, and that a first step in this modernisation will be in commissioning strategic assessments of primary care from each of the health boards as part and parcel of their planning process. So in closing, Presiding Officer, I wish to briefly highlight one final aspect of integrated person-centred health and social care, and that is in relation to ensuring that patients have access to appropriate end-of-life care. And in Dumfries and Galloway, the region I represent, there is an out-of-hours multi-patient service, which is a partnership between Marie Curie Cancer Care, the NHS Dumfries and Galloway and the Alexandra Unit, which specialises in inpatient palliative care. Now, this service is designed to provide care and support for people with life-limiting illnesses and who are very ill outside normal working hours in their own homes, thereby avoiding the risk of their immediate admission to and perhaps dying in hospital. In 2011-12, when a place of death was recorded, 54% were at home against only 5% in hospital. Presiding Officer, what has been announced today by the Health Secretary is an ambitious approach to person-centred, safe and effective care, which, through the support of everyone working together with our primary, acute and social care teams, who do a fantastic and tireless job, is, I believe, the right way forward in enabling our constituents to have a health and social care system that's fit for 2020. I support the motion in the Cabinet Secretary's name.
Thank you very much. And I now call George Adam to be followed by Margaret McCulloch.
Thank you, Presiding Officer. The Scottish Government's ambitious plans for person-centred healthcare is welcomed. The Scottish Government introduced the healthcare quality strategy in 2010 and the three key points of safe, person-centred and effective. And today's debate is more about the person-centred part of the whole scenario, mutually beneficial partnerships between patients, their families and those delivering healthcare services. And I think that's much with what Nanette Milne was talking about previously with regards to the days gone by where health professionals actually talked about individuals instead of talking to them with regards to some of the complaints, and it's something that people have obviously had complaints with in the past, and I think this is a good way to actually make sure that we do. You know, it sounds like some new age form of language talking about person-centred healthcare, but as Mr Findlay quite rightly said, it says what it does what it says in the tin, and that's the most important part about this whole kind of thing. One of the things that Bob Doris brought up as well was the fact that he believed that a good example of this was self-directed support. And I would agree with that as well, because I think that gives individuals the independent living that they all strive for. In years gone by, I worked as a councillor and I was a member of the Renfrewshire Access Panel. And the number of times that, as the council's representative, the debate would not be about access issues or mobility issues. It became about health and social care issues. Now that made me decide that it might be a good idea to have a Renfrewshire Disability Forum that crossed all over all forms of disability, and they had access to health and social care professionals and workers at a senior level so that they could actually make a difference in their local area. And that has worked, because now the last I heard, the last meeting we went to, they actually spoke about access issues and they were doing the jobs they were meant to be doing, and they left that for the Disability Forum. And I think that's about the empowerment. It's making it person-centred and making sure that they get the opportunity to actually be able to see what their problems are and what their issues are. Yes, Mr Findlay.
Neil Findlay.
Maybe if I could mention the other side of self-directed support, where people who are coming to us are telling us that they are part of third sector organisations who provide person-centred support. Their organisation wins a contract, but they can't win it at the level that they won it the last time they tendered. They therefore put in a lower price, they win the tender, and what happens? The day after they win the tender, they're told that for the 6th year in a row their wages are frozen and they're working 2 hours further a week. What does that mean for the quality of care that's been provided?
George Adam.
Well, I would make sure I'm talking about the right debate when I say things, Mr Findlay. That's more a procurement issue than it is to actually talking about the person-centred debate that we're having here today. This is about the individual and actually making sure that we can actually deliver the kind of centre approach that they want. And I would suggest that you probably bring that up at a later date when we do actually talk about procurement. But, you know, people wouldn't be surprised if I'm talking about person-centred healthcare that I mentioned multiple sclerosis, because obviously everyone will be aware my wife Stacey has MS, as do Scotland. We have more people per head per population than anywhere else in the world. And this year they had the Lottery of Care report, which we obviously discussed in this chamber during MS Awareness Week. And it showed that, you know, there was things that in Scotland we were particularly good at, and there was things that we still need to work on. And that was the positive thing thing about this is, after that debate, the MS Society wanted to work with ourselves to create a cross-party group for the first time in this Parliament's history, to actually work with the Parliament, the Government and everyone else to actually see what we could do to make things better, so that we don't come every year where there's an MS Awareness Week and we've got a list of complaints. We're actually working with the Cabinet Secretary and others within the profession to actually make a difference and make sure that we're not just shouting from the sidelines. We're actually taking an active approach in the process. And I have to say that MS in particular is a condition that's specific to the individual. Every individual is individual, and this type of policy, this ideal, is perfect in action for someone who suffers with multiple sclerosis, because it means that you're dealing with them as, I think it was the quote that the Minister used was the fact that they were talking to them about a person as opposed to the condition. And I think that's the thing we have to remember, and we have to make sure that we listen to the individual and we don't just look upon them as a diagnosis or a condition. You know, regardless of the conditions, there are so much things that we can actually do. Keeping people healthy within their communities is one of the things that's probably really quite important. Earlier on in the year, my mother was diagnosed with cancer and eventually died. But during that period, we obviously looked at the idea of, at one stage, it was a year or 2 years, that she would have an opportunity to be at home. And our plan was going to be actually make sure she was with her family, within the community, making things better. Now, things didn't work out for us because things got worse for her health during that period. But I think that's obviously, when you're looking at the person-centred, of course, when you're in that type of situation, of course you have to look at the family and make sure that they are actually within their own family and their community at these difficult times. But one of the other things is, it's not just financially prudent, it's it's actually the right thing for us to do as well. You know, we face, as has been mentioned a number of times, a lot of challenges with regard to our ageing population, and the health and social care integration for adults will help with this, because I think some of the situations we've had in the past has been, I think Siobhan McMahon mentioned, that situations where there was not a join-up in communication or linking, where there might be an elderly person coming out of hospital to try and get home and the care wasn't available, it wasn't there. I think health and social care integration will give us the opportunity to make sure that we can give a complete rounded service for these people and these families in these conditions, because that's what we have to do. We have to have had times in the past where we've had to intervene as politicians to do that, and that should never happen. It should never get to that stage. It should always be part of the service as well. You know, one of the other things that the Scottish Government has protected the health budget. So I was listening to some of the things that Mr Findlay said, and it's not the NHS that I recognise, and it's not the NHS that is actually out there, and it probably is a negative thing the way he talked about some of the workers within the NHS in Scotland as well. You know, my wife obviously has MS and she's a long-term condition. Other people who are genuinely engaged on a regular basis with the NHS don't recognise Mr Findlay's ideal or his belief of what the NHS is. And I think the Scottish Government is to be commended that they've been investing money in the NHS has been a priority. Like the rising to a record of £11.8 billion in the resource budget in 2015-16 just tells you exactly how important that this is to the Scottish Government. So I would just say, Presiding Officer, the NHS is how we care for our people, defines who we are, and the Scottish Government has shown a commitment to this, and the person-centred approach is much welcome. If we do not support the people who we serve, then how are we relevant to them in the long term? I support this initiative and applaud the Scottish Government on their continued support of our National Health Service.
Thank you. And to now call Margaret McCulloch, to be followed by Fiona MacLeod.
Thank you, Presiding Officer. The Royal College of Nursing tells us that person-centred care is one of their 8 principles of nursing practice. It's a holistic approach based on mutual understanding and a relationship between patients and those responsible for their health care. I'm sure it's an approach we can all endorse today. However, the nursing profession also tells us that there are challenges to delivering that holistic approach to care. And so today, I want to highlight some of those issues, particularly in relation to my own region. Firstly, I want to say that we all have to recognise the context in which we're having this debate. From 2010-11, when the coalition government came to office, until 2015-16, when hopefully it will leave, the Scottish budget will undergo a real terms reduction of 11%. That is a difficult context for public services, despite the level of protection that both Coalition and Scottish Government appear to have afforded health spending. But we shouldn't allow a headline commitment offering notional protection for health spending to prevent us from following the money and examining in detail where it's been spent and how that affects healthcare. Our ambitions for the health service should be to shift the balance of care, to prevent ill health through early intervention, to promote healthier lifestyles, to support self-management of the chronic illnesses and long-term conditions, which are already too far prevalent in Scotland due to our health inequalities and our ageing population. Our ambition should be to diagnose and treat people in the community wherever possible in a primary care setting, and to create pathways for patients that better support a preventative as well as a person-centred approach. By getting the balance of care right, we can reduce emergency admissions, prevent avoidable and expensive surgical interventions, and create economies of scale in the NHS without undermining frontline services. By getting the balance of care right, I believe we can ease the pressures in hospitals, especially in Lanarkshire, where we have had long-standing issues with recruiting the right number of consultants for our 3 acute sites, and we can address these constant recurring long waits in our A&E units and bed shortages in our hospitals. What concerns me is that too often we are treating the cause for prevention and shifting the balance of care as some kind of novel idea or recent development. Yet it's been almost 10 years since Malcolm Chisholm, as Health Minister, commissioned the Care Report, and 6 years since Better Health, Better Care. In Lanarkshire, we have not seen the kind of new primary care infrastructure that supports the vision and ambition we have for our health service at that time, or that we have for the health service now. A Picture of Health, the NHS Lanarkshire's response to the Care Report, set out plans for new minor injuries units in health centres across Lanarkshire, which would support a holistic approach to health. We were told that the SNP supported these plans. We were told that all they opposed in Lanarkshire was the decision to downgrade the Monklands A&E unit. Yet here we are, all these years later, and 3 new health centres for Wishaw, Kilsyth and East Kilbride only just had their outline business case approved last month. They were supposed to be commenced or completed within 5 years of the Picture of Health being published, and that was in December 2005. Meanwhile,
Cabinet Secretary.
Can I thank the member for taking an intervention, but obviously our capital budget has been cut by 26% this year alone, and that cut originated from Alistair Darling. It is impossible to meet all the original commitments we made all those years ago when our capital budget has been sliced to ribbons by Alistair Darling and then by the Coalition Government.
Margaret McCulloch.
We are in support of protecting frontline services, and at the moment that's not happening under the SNP watch. Right. A picture of health. Lanarkshire's response to the Care Report set out plans, as I said, for new minor injuries units. Let me find out where I am. Meanwhile, plans for minor injuries units in places like Cumbernauld has been scrapped entirely. All those delays, all those abandoned projects, all that underinvestment in primary care happened under this government, which once promised to keep healthcare local. The result is not just seasonal pressure in hospitals and A&E, which the Labour amendment covers, but recurring all-year-round challenges in Lanarkshire. Weekly figures compiled by NHS Lanarkshire show that they failed to meet the 95% target for patients being seen at A&E within 4 hours, never mind the 98% target in September and October of this year. But it's not just the experience patients have of waiting in emergency rooms which worries me, it's what that reveals about our health service. Pressures which were anticipated years ago are being manifest in our NHS across the country and in Lanarkshire in particular. I support calls from the Labour frontbench for an inquiry into the pressure points of our NHS. I support investment in primary care of the kind people in my region were promised years ago. And I support all those health workers at the coalface whose job it will be to maintain a person-centred service this winter and beyond. We can all endorse the person-centred approach, but I would stress to the Chamber that we also have to do much more to support the people responsible for delivering it. Thank you.
Thank you very much. And I now call Fiona MacLeod, who will then be followed by Mark MacDonald.
Thank you, Presiding Officer. The ambition to have person-centred healthcare is not new, as I know from my many years as a health service librarian. More than 20 years ago, I worked in palliative care, and more than 14 years ago, the Centre for Integrative Care was opened in Glasgow on the Gart Naval Hospital site. So my contribution very much this afternoon, I will warn you now, is that of a health librarian with evidence and references. And that's where I want to start. I think it's fantastic that that ambition has now got a great body of evidence behind it to show that person-centred healthcare is the way forward for treating our patients. But I'm also pleased that we have such great government support for that patient-centred healthcare. Now, the Cabinet Secretary himself said that it would take him 3 hours to list all that the SNP government are doing to support that person-centred healthcare. I've got half a page here, but I'll just refer you to the list that Nanette Milne read out, Bob Doris and Aileen MacLeod, of the work that the SNP government is doing around the person-centred initiative. But for me, the core of person-centred healthcare is health literacy. There's a phrase that I always used to quote from Confucius: I hear, I forget, I see, I remember, I do and I understand. And that's the core of person-centred healthcare, where the patient does healthcare for themselves, therefore understands what they're doing. And there's two aspects that we have to look at in relation to person-centred healthcare. There's a therapeutic relationship where the patient is a partner in their healthcare. Nanette Milne referred to the dark days of the 90s, 50s and 60s when the patient was talked at rather than talked to and talked with. But the other aspect is also therapies. When we're talking about patient-centred healthcare, we need to look at the therapies and the therapeutic environment that we're treating our patients in, and we need to look at the whole person and the holistic care of that person, and not just the treatment of the illness that they've been diagnosed with. In terms of the therapeutic relationship, we often talk about the expert versus the passive recipient, that is the doctor versus the patient. But many of us would say that the expert in that illness is that patient. And George Adam alluded to that when talking about multiple sclerosis. But that doesn't mean that the patient is there without that relationship with their clinician, because the patient is the expert in the illness, not the medicine to treat the illness. And I absolutely fundamentally believe that if you're talking about this therapeutic relationship where patients are partners in their healthcare, then it's about access to high-quality health information. That's to say that both the clinician and the patient have access to the evidence base about the treatment that is going to be used and followed through. Access for both of them. Many years ago, when I left this place in 2003, when I lost my seat, I went back into health librarianship, and in the 4 short years I'd been in Parliament, hey-ho, I went back to discover the e-library, which was this most amazing resource which every health professional in Scotland, in the NHS, could get access to via a computer and get access to the peer-reviewed evidence base for everything they did in their work. That's now called the Knowledge Network. It grows and continues. What I would love to see is that it's not just every clinician that gets access to it, but every patient as well. But we have to have health literacy in order to access the information, but also assess it and work out how to apply it to ourselves. But also we have to look at holistic therapies when looking at patient-centred healthcare. And I've got a few quotes I would like to read out on the fact that we're not just talking about medicines and operations here, but we're talking about holistic, integrative healthcare. And if I can just read out a few quotes. There is a growing body of evidence for integrative interventions such as mindfulness-based therapies, self-efficacy and self-management strategies, and wellness enhancement. I think that's a lovely expression, which all build self-awareness and inner resource development skills for patients. And the ethos of this approach is to enable a person to rediscover or rebuild their own inner resilience, strength and creativity in order to engage with effective self-care and self-management. It is an inherently individualised, person-centred and whole-person approach. Evidence from interpersonal neurobiology and empirical research into compassion and empathy forms much of the bedrock of this approach. Current research indicates that the activation of a person's self-care abilities can trigger lifestyle changes, such as healthy nutritional and exercise choices, as well as an attitudinal shift supportive of successful long-term outcomes and ability to cope. So I think it's incredibly important when we're talking about person-centred healthcare, we're talking about the whole person. But can I move forward from just the whole person, the patient, and talk about carers and their family as well? Because if we're doing person-centred healthcare, then it's the person comes with their carer, with their family. And there's empirical evidence that the involvement of carers in a patient self-management initiative significantly improves therapeutic adherence with resulting improved outcomes. So this is what person-centred healthcare is about. It's what I, as a professional, 20-odd years ago, we were working towards, and I'm delighted that what we now have is a fantastic evidence base to prove that person-centred healthcare is the way forward. Just before I close, Presiding Officer, George Adam talked about not recognising the health service that Neil Findlay referred to, and I have to say I agreed with that as well. Neil Findlay and Annette Milne talked about the casework that came to them about people with problems in the health service, and that casework is reflected in my own. But can I remind you on Mark MacDonald's intervention that the casework that we get are the approximately 10% of patients who have had an unsatisfactory experience in the health service. And if I could perhaps refer to my experience as the carer for my mother with her multiple morbidities and possibly 5 healthcare emergency admissions a year, and I am one and she is one of the 93% that are satisfied with the care that she gets from the NHS in Scotland. So in conclusion, Presiding Officer, patient-centred healthcare is about patients as partners, and that ultimately leads to less patients, but it also leads to effective and engaged practitioners. And is that not the way that Scotland would want to see its NHS? Thank you.
Many thanks. I now call Mark MacDonald to be followed by Malcolm Chisholm.
Thank you very much, Presiding Officer. We've heard much about what person-centred healthcare and person-centred support is, and it was highlighted to me a 2011 Joseph Rowntree Foundation report, Transforming Social Care, Sustaining Person-Centred Support, which took a bit of time to discuss with participants how they would define person-centred support. And some of the terms which were put forward as key components were putting the person at the centre rather than fitting them into services, treating service users as individuals, ensuring choice and control for service users, setting goals with them for support, emphasising the importance of the relationship between service users and practitioners, listening to service users and acting on what they say, providing up-to-date accessible information about appropriate services, flexibility and a positive approach which highlights what service users might be able to do, not what they cannot do. And I think most of those are terms which we would all accept as being important in developing a person-centred approach. It was interesting to read the quote that started the report from one of the practitioners involved, who said, "It's not another job, it's the job. Person-centred support is not another thing that you have got to do, it is what you have got to do." And I think that is a message which I'm sure is getting across both from the direction that is being given from government, but also in terms of the work that is being done by health professionals to ensure that the person-centred support is paramount. Another report which was highlighted to me was one from the University of Stirling, Person-Centred Care, What is it and how can it be improved? And it looked at two what you could call guiding principles, which is to look at where each individual feels they've been recognised and responded to as a unique human being with intrinsic value and a personal identity, life story and life plans that matter but that may be vulnerable in healthcare contexts, and B, an individual with a capability for developing and exercising autonomy that matters, but that is vulnerable in social contexts, including healthcare. So recognising the individual at the heart of the process and making sure that things are worked with the individual, not the individual worked with the process. And I did take on board the points that Mr Findlay was raising in his contribution, but he must first of all accept that we have made progress in terms of accident and emergency, maybe not to the extent that we would wish to see, but if you look at what we inherited when we came into government, in terms of 87.5% of patients who were waiting for less than 4 hours, 87.5%, there has been a significant improvement in terms of the waits of less than 4 hours since we came to office, and I'm sure he would at the very least be gracious enough to acknowledge that.
Neil Findlay.
Well, I'm sure the member would be very gracious enough to acknowledge that because they couldn't meet the targets, the Cabinet Secretary had to change the targets.
Mark McKinlay.
Well, thank you, Presiding Officer. Good to see that Mr Findlay does not accept the progress that this government has been making on accident and emergency waiting times. But the point that I made to Mr Findlay in his speech, and he seemed to take amusement at Fiona MacLeod re-emphasising this, is that he said that when I quoted from the national survey, and I'm going to quote some of the figures from that again, that it's all well and good to quote surveys, but I want to quote the people who come and see me at my surgery. Well, I get people coming to see me at my surgery as well, as I'm sure every MSP does, about their individual experience with the health service. The thing is, people come to you if they have an issue that needs to be resolved. So the people who have had a fantastic experience in the health service generally aren't going to turn up at your surgery just to tell you that they had a fantastic experience in the health service. Now, that is not in any way to denigrate or undermine those people who have had an unsatisfactory experience within the health service, because it is important to do all that we can to ensure that everybody has a fantastic experience in the health service. But we have to accept that that is never going to be possible for every single person who goes through the health service, because by its very definition, it is a human organisation, and all human organisations are fallible, and there will be those occasions where an individual does not have the experience that they would wish to have or that we would wish them to have. But it's important that lessons are learned from those experiences and applied, and ensure that they are not repeated again in future. That is what we must ensure that we do when dealing with these kinds of things with health service. I will give way to Dr Simpson on that.
Richard Simpson.
Thank you for taking an intervention. We passed a patient rights bill, which is an excellent bill, with a new complaint system with the 4 Cs in it. That was compliments, comments, concerns and complaints. Why are we not getting reports, both to health boards and from health boards to the Cabinet Secretary, of a composite collation of all those reports? Because we're not getting it yet. And without that, we can't get a balance of the sort that Mr MacDonald is seeking.
Mr MacDonald, give you a bit of extra time.
That's an interesting point that Dr Simpson makes. I'm sure it's one that the Cabinet Secretary and the Minister will take on board. I don't think I can make a commitment on their behalf. Well, I could, but I don't think they would thank me for it. But can I also say that it is good to see Dr Simpson back in the chamber. I have missed his contributions at Health Committee recently, and want to welcome him back to his place. But to turn to the national survey, Presiding Officer, I quoted I was treated with care and I was treated with respect scores of 93% and 92%. Respectively. There were a number of areas. For example, I had privacy when being examined and treated, 95% positive response. The ward or room I stayed in was clean, 93% positive response. So the general consensus out there is that there is positive response from patients in respect of their experience with the health service. Now, that is not to say that we shouldn't always strive to improve, and that is what we do. We strive to improve. I want to turn to just one last part of the motion, which talks about making GP services more accessible for patients. And I want to look at a local example in my own constituency, the Dainston Patient Participation Group. I met the group at the Dainston Gala in the summer, where they were involved with the Dainston Medical Practice stall. Essentially, it is a sounding group and a forum for patient involvement with the GP practice. They discuss potential improvements that could be made, which would help make the experience of the practice better for patients, but they're also often a sounding board, or can be asked for their thoughts about new legislation coming into operation which would concern patients. They recently have hosted evening meetings on topics such as asthma, men's health and diabetes, looking at bringing in patients from within the practice concerned in these areas. And recently they had a gathering seminar which was entitled Thinking Ahead, Preparing for Winter, where they brought in elderly members of the community, talked to them about how they could make appropriate preparations for the winter to ensure that they maybe reduce the risk of slips and falls on their paths, for example. They brought in the local police, the doctors from the practice, and had a discussion around how people could prepare for the winter. I think that's a very interesting approach that is being taken there at Dainson. I'm aware that there are other GP practices across Scotland where that approach is taken, but I wonder if it's something perhaps the Cabinet Secretary might want to look at in terms of maybe applying that more widely and looking at whether those kind of groups could be something that could be introduced in other areas to ensure that the GP practice is not just the place you turn up where you're sick, but where you feel that you've got an involvement in developments relating to the practice and helping to ensure that it improves in a way that patients would want to see. So I leave that on the table for something for the Cabinet Secretary to consider. I'd be happy to discuss with him and the Minister afterwards if they wanted to find out more.
Many thanks. And I just let the Chamber know that at the moment there is plenty of time to take interventions and the encouragement of lively debate. Mr Chisholm, to be followed by Mr Hepburn.
Presiding Officer, person-centred care is defined in the Scottish Government's quality strategy as, and I quote, providing care that is respectful of and responsive to individual patient preferences, needs and values. Words, in fact, which directly echo a description of person-centred care by the Institute of Medicine in its seminal work, Bridging the Quality Chasm. In more detail, I would say that person-centred care is about recognising and responding to patients as unique individuals, supporting patients' personal autonomy and ability to make choices about their care and treatment, being flexible in responding to each patient as a person, and emphasising, as the Macmillan briefing sent to us today does, emphasising the relational aspects of care, especially the principles of dignity and respect. So I think that collection of phrases gives us a good starting point for the description of person-centred care. Another way of looking at it is it's the opposite of the kind of paternalistic and often aloof approach to the care of patients that was so common in the past. And the reality is it's not unknown now, and unfortunately as MSPs we do sometimes hear examples of that unacceptable attitude that was so common in the past. But since the Cabinet Secretary has been concentrating on primary care today and GPs in particular, I should say that my own GP is a model for person-centred care in action, and I'm sure we can all think of many clinicians who would in fact fit in with that statement. But it's not always the case, and I think that's not always the case either in primary care or in hospitals. So I understand why the Cabinet Secretary wanted to turn today's debate into a debate about primary care, but the reality is a lot of the concerns about the absence of person-centred care are about what happens in hospital. Now, Neil Findlay was absolutely right to relate this debate to pressures on the system. There are time pressures in primary care, of course, but there are even more acute pressures in our hospitals, and that does make the achievement of person-centred care much more difficult. So I think we should certainly acknowledge that in the debate today. And the reality is person-centred care wouldn't automatically flourish if the pressures in the system ease. So specific actions have to be taken to make the service more person-centred. And of course some actions are being taken, which I'll refer to in a moment, but we should also remember, of course, that some developments towards personalised care will actually happen because of scientific advances. In the cancer debate 3 or 4 weeks ago, we talked about developments in drugs, which means that medicines will be more targeted to a specific individual. So that will happen, as it were, independently of these other actions that we have to take to address the relationship between clinicians and patients. Now, we've had several examples mentioned today. For example, the Health and Care Collaborative. I wish the Cabinet Secretary had said more of that, because that seems to be a critical initiative to improve and advanced person-centred care. But we've heard on many occasions, over many years in fact, about the involvement of patients in service redesign. That's another important way of helping to create more person-centred care. Many examples could be given. The Minister, who's going to wind up, spoke at the Spina Bifida reception last week about the Neurological Alliance and the good work that they're doing. One of their projects is Neurological Voices, which is to do with training and involving people who have suffered from neurological conditions to be involved in developing and redesigning the services. We also all know of many positive examples of personalised person-centred care in the NHS. And again, in this chamber, I seem to remember debates, certainly the MS debate, but also the Parkinson's debate a few months ago, when particularly clinical nurse specialists were being praised as absolute models for person-centred care. And of course, today we also heard from Mark MacDonald and Nanette Milne about the patient experience surveys, which are another important feature of person-centred care. But of course, in those surveys, we have to ask the right questions and act on what we find, because patient-centred care is not just about better care for an individual, but about improving the quality of care for all. And I started by talking about the quality strategy of the government, and I think this whole issue of person-centred care has to be put right bang in the middle of the quality agenda. And I hope members will forgive me if I quote two sentences only from a speech I gave more than 10 years ago on the 18th of June 2003, because when I was thinking about this debate, I thought, I said a lot of those things then. And this is what I started by saying: the starting point for improving quality must be the experience of every patient who passes through the healthcare system. We might be missing important aspects of patients' experience because we are not asking them properly or not asking them at all. And that's why I thought it was important to fund research into patient experience, and obviously patient surveys are another feature of that. But you have to ask the right questions and you have to act on your findings. So I think there has been some progress there, but I think there is still quite a long way to go, because I think that is absolutely key to improving quality. And if we're learning from patients' experience, that in itself, the quality is going to be very much centred on better person-centred care. Now, I agree, of course, with the Cabinet Secretary in his criticisms of the English health system. But I think two things about this. I think we shouldn't be too complacent about how much better we are. I think we are better as a system, but I also think we should look to England, because many of these issues are the same in England, and many of the actions being taken in England are also trying to improve person-centred care. So I have been very struck by Jocelyn Cornwall, follow her on Twitter, you can all follow her on Twitter, who is director of the Point of Care Foundation. And I think if you look at the work that they're doing in terms of improving the delivery of compassionate patient-centred care, focused to some extent on, no doubt, similar work to the collaborative in terms of developing and working with clinicians in order to develop that kind of care. But I just think we need to be a little bit careful in criticising the English health system, that we don't cut ourselves off from the many examples of good practice and good developments in England that we could actually learn from as well. So that would be my last word. But, you know, basically, I think we are all moving in the same direction on this, but we have to remember the points that Neil Findlay made. All of this becomes difficult, very difficult in a system under pressure.
Many thanks. Now call on Jamie Hepburn, to be followed by Richard Lyle.
Thank you very much, Presiding Officer. And can I say I admire Malcolm Chisholm's ability to remember what he said 10 years ago. I struggle to remember what I said in debate last week, and I wish that I was joking. In welcoming today's debate, can I say I think the quality of healthcare is a key concern for all people that we represent. It's not every agency that everyone will have to interact with, but I think everyone will have to interact with the NHS at some stage in life, be it attending their GP, planned care at hospital, or presenting an accident emergency. And indeed, as it's been mentioned, I can't help but reflect on the fact that in 2012 there were some 68,483 attendances at Monklands A&E, which is the A&E that serves my constituency, indeed the constituency of the Cabinet Secretary. So how the NHS deals with individuals is clearly important, and frankly I think a person-centred form of healthcare has to be viewed as the only type of healthcare worth having, and by and large I think that is the system we do have. The NHS is staffed by thousands of dedicated individuals who are motivated by patient care. I think we can reflect on the quote that Mark MacDonald gave from the health practitioner that really got to the essence of that. That is what motivates the people who work in the NHS. And of course, I think this has been reflected on by a number of contributors today. Malcolm Chisholm just made the point in the last contribution. There are circumstances where the NHS lets people down. It doesn't meet the standard it should. We will all have that experience of constituents bringing cases to us, to our attention, where that has happened. Of course, the task for us is to deal with that individually, take forward and try and resolve the problem for them. But of course, the health service has to learn the lessons of such experiences where appropriate to try and ensure that the concept of a person-centred healthcare remains the driver for the National Health Service. I do think we should, and again this has been commented on, I think we should reflect on the fact that satisfaction with our National Health Service is high. The Scottish Household Survey 2012 found that 87% of people were satisfied with local health services. That's up some 7% over the lifetime of the current Scottish Government. And I think that's something that we should all welcome. That clearly suggests to me that people, their experience of the health service is a good one, but we shouldn't run the risk of complacency. We should be willing to continually respond to calls for further improvement, placing the person at the centre of healthcare. And indeed, we've seen the Scottish Government doing that in recent years. I was very pleased to see the Cabinet Secretary for Health and Wellbeing responding to patient feedback and piloting extending visiting times in 5 health board areas. And I think that came on the back of his own back to the floor visits to hospitals across Scotland. That was welcomed by Jean Turner, who is known in this place and now in her capacity as Chief Executive of the Scottish Patients Association, welcomed that move. And that is essentially a small change, Presiding Officer, just extending visiting hours, but it does respond to the concerns of patients and their families, so it can make a big difference to the individual. And I think it would be very helpful if the Minister, in closing, can tell us what the early lessons from these pilots might have been. Bob Doris and Aileen MacLeod also mentioned the investment of some £4 million to trial innovative approaches to ensuring the NHS is a genuine 7-day service, so that pharmacists, physiotherapists, porters, all the kind of services that we need for patients to move through and be discharged from hospital are available every day of the week. And again, it would be useful to learn what the early lessons of these pilots are, because it is, of course, important to ensure that the relevant staff are in hand to ensure that no one is in hospital longer than they need to be because of the costs involved. But I think also it's important to ensure that they're not in hospital any longer than they want to be. No one wants to be in hospital any longer than is absolutely necessary. So we can make sure that they are discharged when they're ready to be discharged, rather than having to wait for the relevant health professional to be available. The point made by Bob Doris, then we're seeing a more effective and efficient health service, reducing costs in the health service, but also a more patient-centred health service as well. I think it's also important to mention the role of the Change Fund for older people. I think that can also play a role in improving person-centred healthcare. I know that the Change Funds are obviously an important part of the preventative spend agenda, ensuring better use of public funds. And as a member of the Finance Committee, I know how important that is, how vital it is to ensure better use of such funds at a time of straitened finances. But I think more important than that even is improving outcomes for individuals through the use of these funds. If we can make sure that people are more active, if we can ensure their care is delivered differently, then that can reduce the requirement for hospital admission. And again, that's better for the NHS and better for the individual. And I was very happy recently to meet Cumbernauld Action Care for the Elderly, an organisation I know the Cabinet Secretary knows well, and they were able to tell me the work they are undertaking with NHS Lanarkshire and North Lanarkshire Council to deliver part of the Change Fund locally, delivering some really imaginative local projects, putting people at the very centre of those projects. And again, it will of course be critical to ensure that the change funds are working effectively. That was something I was able to raise at the Finance Committee yesterday. It will be important for this Parliament to look to see if this investment is making a difference on the ground. I want to now, if I can, President, also raise what might be felt to be a difficult issue. Nanette Milne and George Adam raised it, and that's a person-centred healthcare at the end of life. We all had a briefing from Marie Curie, and they were placing the importance in ensuring that people have greater choices as they come to the end of their life. I mean, we rightly think of person-centred healthcare being about working to get people better, or people supporting people to deal with and manage whatever condition they may have. But we all know that sadly medicine has its limits. So how we can care for a person at the end of their life and ensure dignity is important. I know Marie Curie have made a number of recommendations which I'm sure the Government are aware of, and it would be interesting again to hear how they might be responding to those requests. To close, Presiding Officer, I do believe the Scottish Government is doing what it can to ensure a person-centred healthcare system. We've seen a range of action over recent years. We've seen the Healthcare Quality Strategy in 2010. We've seen the 2020 Vision for Healthcare in Scotland. We've seen 4 quality ambition delivery groups, including a person-centred delivery group set up, and of course the person-centred health and social care collaborative. I think that's real action to ensure that we have an NHS that can serve all of the people of Scotland in the 21st century and moving into years ahead. Thank you, President Officer.
Thank you. Now call on Richard Lyle, to be followed by Duncan McNeill.
Thank you, Presiding Officer. Person-centred planning is based on learning through shared action, about finding creative solutions rather than fitting people into boxes, and about problem-solving and working together over time to create change in a person's life. In order to have a truly patient-centred healthcare system, it must be built on solid principles. Firstly, respect. Both patients and carers should have the fundamental right to healthcare that respects their true unique needs, preferences and values, as well as their independence. Secondly, choice. All patients should have the right to participate in decision-making processes regarding their care, up to a point where they are comfortable in making those decisions. In order to achieve this, it requires that Scotland has a responsive health service, which I believe it has, which provides suitable choices in treatment and management options that fits patients' needs. Thirdly, patients should be involved in health policy. They deserve to share the responsibility of healthcare policy making through meaningful engagement at all levels of the decision-making process. This should not be restricted to healthcare policy, but include social policy that will have an impact on patients' lives. Fourthly, all patients should have access to the healthcare services required by their condition, including treatments, preventative care and health promotion activities. Provisions must be made to ensure that all patients, regardless of their condition or location, have access to the necessary services. It's not just enough to treat the illness. A person-centred healthcare must consider non-health factors such as education, employment, family issues which impact on the patient's approach to healthcare choices and management. Lastly, accurate, relevant and comprehensive information is essential in order to ensure that patients and carers make informed decisions about their healthcare treatment and living with their condition. The information provided to patients must be presented to the patient in a format which takes into account the person's condition, language, age, understanding, abilities and culture. We have, I would suggest, one of the best health services in these islands. It already supplies excellent round-the-clock care, and patients across Scotland can access the health service day or night. I had the good opportunity some years ago, before I came to this place, to drive for the out-of-hours doctor service for 2.5 years. I worked in Wishaw, I worked in Monklands, I worked in Hare Myers, and also worked in Lanark. And I saw the out-of-hours service and the A&Es in those hospitals second to none. The NHS is truly a 7-day service. All aspects of the NHS, including pharmacists, physiotherapists, porters, etc., must be on hand to help patients have the support they need to return home when it's best for them any day of the week. In order to improve the service patients receive within the NHS, I note the Scottish Government is investing, as already has been stated earlier, £4 million across 5 major health boards in order to examine innovative approaches to healthcare and how to deliver them across the NHS. I am pleased to note that the Cabinet Secretary, Alex Neil, has committed to implement the recommendations of the Royal College of Physicians' recent report in order to achieve the needs of the patient and involve them in the decision process of their care. These recommendations include extending the role of hospital physicians into the community, having a consultant presence on wards over 7 days. Care for patients should focus on their recovery and enable them to leave hospital as soon as clinical needs allow, and give appropriate care in the community if required. The Self-Directed Support Act is designed to give those who require community care more choice and control over the social care they receive, and will integrate the language of self-directed support into legislation. The Act will also extend all 4 self-directed support options to children who receive care services, which will ensure that children with disabilities have access to the same support as their non-disabled peers. In keeping with patient-centred healthcare, the Act places a duty on councils to provide advice and information to support people to ensure that they have the information they need to make informed decisions on the support they want. It is widely considered that patient-centred healthcare is the best way to provide care for patients by allowing them access to decisions made on their behalf. And the best way to continue with patient-centred healthcare is to have, I would suggest, a Scottish NHS that remains publicly funded, publicly delivered, and not to follow the disastrous Westminster privatisation agenda which this present Conlib government are doing in England. A Westminster government who have reneged on a pay rise for health workers in England, whilst this SNP government has said it will pay the rise as promised for Scotland health workers. I have total confidence in the work being done by the Cabinet Secretary and also the Minister. I hope that people within this place will support both of them in the work that they are carrying out on behalf of the people of Scotland, and I support this motion today. Thank you.
Thank you very much. Now call on Duncan McNeill to be followed by Gil Patterson.
Deputy Presiding Officer, I'll begin as many others have done and quote some understandings of person-centred care. The NHS Scotland Quality Improvement Hub defines person-centred care as providing care that is responsive to the individual personal preferences, needs and values, and assuring that patients guide all clinical decisions. Whilst Inclusion Scotland welcomes the move towards person-centred care, we are concerned that this approach remains focused on the management of conditions and not on the wider needs of the person, such as access issues, how they are treated by others, and support for independent living. And I think it's important to say that today because there's been many definitions about what personalised care is. And it would be nice, I think, if somebody will count them up about all the definitions here today, and everybody seems to have their own individual one. But it would be a nice start if we could all agree between those who receive the services, those who provide them, government that's trying to develop policy and legislation, we can actually agree a clear definition about what purpose we're chasing. But what is not in dispute is action from all of the parties in terms of developing policy to move in the direction of personalisation of care, although that is, I think, maybe still ill-defined. We also could, I believe, agree that progress on this journey has been slow and is frustrating. And there were some speakers here today who believe we're bounding ahead and everything else, and you know, no problems at all. And I think that borders on complacency. I believe that the recent legislation on self-directed support, which we supported and welcomed, and the Public Bodies Joint Working Bill, which we're working on now, is actually evidence of that shared frustration about how we move this on. And we've come up against many barriers which we describe generally as a culture shift and a lack of leadership and whatever. But there's no accusation against this government, or indeed others, that they have tried to tackle this issue. Where we are, I think, as a group of politicians supporting the government is looking for more sustained action and outcomes. The Health and Sport Committee inquiry into elderly care some 18 months ago highlighted many of the issues raised in the debate today. While the inquiry brought about a U-turn in the inspection of care homes, and we welcomed that, we also made recommendations in regards to the impact of procurement and commissioning. Something that was described by one of the members today has nothing to do with this debate. Well, there's been two committees of this Parliament that I have convened, the Local Government and Communities Committee, when we were confronted with a panorama programme about e-procurement and its impact, disastrous impact, on the care of the elderly. We had an inquiry at that time, and the e-procurement didn't survive a week. It never survived a session. So procurement and commissioning, unfortunately, in the world that we live in, and has consistently impacted on the care that we provide on a daily basis. And all of our ambition to deliver more and more of health services at home, which clearly people want, whether there's pots of money or whether the budget's shrinking or whatever. This is the right thing to do, irrespective of budgets. How do we sustain that move when we have commission and procurement policies that bring about the 10-minute visit, which is bringing great reputational risk and damage to care in our communities? There's a complete absence of continuity of care, which is a recognised principle right across the provision of care. 6, 7, 8, 10, 28 over a month's period of carers into your home, not knowing who this is an issue that needs to be dealt with. We also called for a review of the national care standards, in that inquiry. That was, as I say, the inquiry was 18 months ago. The national care standards now are 12 years old, and maybe the Cabinet Secretary can say something about in response to the procurement and the review of care standards when the Minister winds up. He may want to say something about that. But the lack of progress and the impact, and the lack of impact on policy or standards or guidelines or legislation isn't a dry matter. These matters are very personal indeed. One of the other outcomes about the inquiry into elderly care was the announcement by the previous Cabinet Secretary of the inspection of elderly care services in our hospitals. And they have, the inspections produced by Health Care Improvement Scotland have emphasised the lack of the personalised care plans that meet the needs of patients in the acute hospital setting. Indeed, the most recent inspection report was at St John's Hospital, NHS Lothian. It was an unannounced inspection, which comes a full 2 years after the test inspections, which showed the same things, which highlighted the very same issues. States, in relation to care provided to dementia patients, care plans were generic, pre-printed documents which were not specific to the needs of the individual patients, this does not provide a clear record of the care required and given to a patient that does not demonstrate the evaluation of that patient's care. 2 years, report after report, despite government push, direction, announcement Cabinet Secretary, on the ground, we have an issue here that we are not delivering. I met yesterday, and talking about the primary side, I met yesterday with David Robertson of the Learning Disabilities Advocacy Group. Still doing a really good job with the Health Board and the government's support, ensuring that publications are fit for use for people with learning disabilities. But they are campaigners in this area, still campaigning for a voice with their GP. We know that they're entitled to an annual check, but they still have problems, calling, visiting the GP. They complain about GP staff, GPs receptionists. I reminded them, many of us have had cause to complain about GP receptionists, but the lack of training there that engages them, although the government policy and drive is to create change there, their experience tells a different story. But we also need to obviously recognise the challenges that we have. This is, as others have said, a journey that we all hope to arrive successfully. There is dramatic increasing demand. There is less public money. There have been efforts of government present and past. There has been cross-party agreement. There has been change funds. There have been changes direction in the budgets. The only thing that I believe that is missing now, the only people not at the table, are those people that are in receipt of these services. They're missing. The people who are debating this are the politicians and the budget holders. It's time that people power came to the table to ensure that we get a change of culture where those organisations, those people who have positive rights to ensure change that they deserve. Thank you.
Thank you. Now Colin Gill-Patterson, after which we move to the closing speeches. Mr Patterson, a generous 6 minutes.
Thanks very much, Presiding Officer. I'm pleased to participate in this debate, being a member of the Health and Sports Committee. From listening to the members and looking at the motion and amendments, it's plain to see that across the chamber, everyone supports the principle of person-centred healthcare. I think summed up extremely well by Malcolm Chisholm, who described it as all travelling in the same direction. I feel that this is a very positive aspect to this debate, as we all strive to achieve an approach that will bring benefit in health and treatment for the people of our country. The NHS is something that we all hold dear, which at one point or another we, or certainly a family member, have had need to use. Every one of us has a stake in an NHS, and it's paramount that we all are involved in making it work. The staff across the NHS should be commended for the work that they put into looking after others, especially at this particular time of the year when cold weather brings extra strain on the system, and that is certainly recognised by the government. It's times like now that we truly appreciate the hard-working staff of the NHS, and I'll speak about that later on. For the NHS to continue to deliver top-quality care, it's imperative that patients and families are at the heart of everything that is delivered. But it must be acknowledged that the treatments can take all forms, from within hospitals to within the community, and that these must be a dialogue with patients to ensure that the best possible care is provided, taking into consideration the needs of the individual. That's why I was pleased to speak in favour of and support the Self-Directed Support Act, which was passed by this Parliament last year. The main aim of that Act was to ensure that those who required community care had the independence to make their own decisions over the care that was provided and needed by them. I felt that this was a very important move, as it gave those people who were generally removed from society due to their illness or their condition the opportunity to become actively involved and respond to their own caring needs. Giving patients that independence is a very important aspect of person-centred healthcare. And I would argue that this motion builds on the measures contained within that very Act. When focusing on delivering the best health outcomes, not only is it important that we involve individuals, but it is also important to speak to and engage with local communities as a whole. Recently, in my constituency, I carried out a survey on accident and emergency provision, which attracted a large percentage return rate. It's not really a surprise, actually, but never mind. We'll talk about that again. Whilst many of those who responded focused on the accident and emergency provision that was the basis of the questionnaire, a number expressed their general feelings towards other aspects of the NHS, including access to GPs and other wide-ranging services provided. It's therefore to be welcomed that the number of GPs working across Scotland has risen by 262 since September 2006, a 5.7 increase. In many cases, GPs are in the front line of healthcare, with the most people seeking access at first through them, rather than any other aspect of the NHS. That's why I'm pleased to see that the heat targets introduced by the Scottish Government to ensure 48-hour access to an appropriate member of GP practice team have been met by nearly all of the health boards across Scotland. There is still work to be done, but this progress is a sign that the Scottish Government is not resting on its laurels. When dealing with illness, it must be acknowledged that illness does not take a break, so we must have measures in place to ensure that patients and families have access to the NHS all the time and in all times. That's why I'm pleased that the Scottish Government is investing £4 million to trial innovative ways to ensure that we have a genuine 7-day service in the NHS. This was another priority item highlighted in the returns in my survey by a number of people who were seeking convenient access times as well. Yet another issue that my constituents raised in my survey was the rigid aspects of visiting hours that were in place in hospitals. They argued that these hours did not take individual needs, family pressures and financial constraints into consideration. In my own constituency, the Golden Jubilee Hospital will take part in a pilot user-friendly scheme which will see extended visiting hours. I'm sure that many of us in the Chamber will have intimate knowledge of the impact on patients' mental health from being in a hospital all day with very little contact with the family members and friends, so this is certainly most welcome. I hope the results of the scheme will see it being rolled out across the country to the benefit of all the patients in Scotland. Back to my survey, and it's really surprising just how many people are engaged in my own constituency at that one given moment. In some regards, it's alarming there are so many people involved. But it's certainly gratifying, although I was asking specific questions on a particular subject, that people took the opportunity to sit down and write some quite long letters explaining exactly their own experience that has recently taken place, and the gratitude that they expressed in their letters, very, very personal letters on things that had been provided in the health service. And I think that's something that everybody in here, to be quite frank, right across the chamber, should be very proud of. This motion represents progress to move forward, not as a means to an end, but to build on the important work carried out in the NHS at the moment, so that we never stop trying to perfect a system of healthcare that continues to deliver for our patients and families and staff. So the next time when I write out a survey, maybe we'll get even more nice letters back complimenting the work, not only of this government, but of this Parliament and the way that we deal with matters in the health service. And I commend the motion to Parliament.
Many thanks. We now move to the closing speeches, and I call on Jim Hume. Up to 8 minutes, please.
Thank you, Presiding Officer. We have had a very wide-ranging debate this afternoon, as was predicted by the Cabinet Secretary himself. The government motion we debated this afternoon, I think, is sound, and I do fully support the principles of person-centred healthcare. I think Duncan McNeil was quite correct to say that we have to define what person-centred healthcare is and make sure that there is power to the people that actually use the healthcare. As I said, it's a motion I feel I can support. Neil Findlay was quite right to say it has to do as it says on the tin. We have had stats from various sides about satisfaction levels, but also missed targets, and also postcode differences, different areas having different access, especially to cancer access. Neil Findlay was and of course Nanette Milne both mentioned one of a gentleman who had to stay 12 hours on a trolley, and Nanette mentioned a 90-year-old man and an elderly lady who had an elderly lady herself being moved from ward to ward and being discharged when her home wasn't ready and unable to use a Zimmer. So although there is high levels of satisfaction, there is work to do, and if there's one or two people still not getting complete satisfaction, we have to try and address that, of course. I was interested in the Minister's remarks regarding his looking into access to GP appointments. I think that's good work, and that the BMA is going to be working with the government. I think, again, Duncan McNeil's point is important, that we keep people involved in that process too. I'm also interested in the Minister's views on some of the anomalies we get with the appointment situations, where you can ring up on perhaps a Thursday afternoon, for example, you are ill. Because it's not an emergency, they'll say, we've no appointments we can give you tomorrow, but if you ring back at 8:30 in the morning, we'll try and fit you in then, which to users is really quite bizarre, and I know it's been on the go for some time. I was also interested regarding Bob Doris's bringing pharmacists into the debate, and I know for some time the pharmacists have been interested in gaining better access to patients' records so that they can do some of the work that GPs do, especially regarding repeat prescriptions or so. So I'd be interested in the Minister's views on that. I said at the beginning I'd mention a bit more about mental health, which is part of my amendment. I felt that in a debate discussing a crucial approach to the delivery of healthcare in Scotland, it was vital to introduce mental well-being into the discussion. The publication of the mental health strategy was a welcome move, as was the opportunity to debate it earlier this year, but the challenges still remain stark. 1 in 4 Scots will experience mental ill health at some point in their lives. The resulting socio-economic and personal cost associated with mental health problems is estimated to be in the region of £10.7 billion each year, and as it is the dominant health problem amongst people of working age, it's estimated that the cost to the employers is in excess of £2 billion a year. On that point, yes.
Yes, I just...
Bob Doris.
The member mentioned about mental health issues, and you mentioned mental ill health, and I accept that. But I wonder if you'd agree with me that we all have a mental health that needs nurtured consistently along with our physical health, and that if more consideration was given to that within health and social care, then preventative measures to stop mental ill health, if you like, although that is an unfortunate term, from ever happening in the first place.
It is. No, I couldn't agree with Bob Doris more than that. The earlier you can detect any form of illness or health problem, the better chances of a better outcome. I stated earlier that the person-centred healthcare is defined as being responsive to individual preferences and needs, and more often than not, the desire and needs of those suffering from mental health is for someone to talk to. That's why there are such incredible demands on the time of clinical and other applied psychologists across this country. And with just 13 months until the heat target for accessing psychological therapies is to be met, we are just at 81% of patients being seen by a psychologist within 18 weeks. I think this is more or less what Bob Doris's point is, which in itself is quite a long time to wait if you're suffering the trauma of mental ill health, and will likely have done so for some time before actually visiting a GP to seek that referral. So it is important to have early access. And again, unfortunately, there are regional variations. Only around 60% of patients in Forth Valley and Lothian are seen within 18 weeks, with the figures in Shetland and the Highlands also being significantly under the national average, albeit I know we have 13 months to go, so hopefully we will get there. Similarly, when you analyse the distribution of psychologists across the health boards, the same picture emerges. There are 15.7 psychologists per 100,000 in the population for Glasgow and Clyde, but just 8.6 half in neighbouring NHS Highland. And there are 15.2 per 100,000 in Fife, but less than half of that next door in Forth Valley. And I've mentioned this before in the Chamber. I've heard anecdotal evidence of some GPs refusing to refer patients because of the length of some waiting lists in certain areas. This is clearly not acceptable. And to be fair to the Scottish Government, there has been an increase in psychologists in recent years, with the impending heat target almost certainly to thank for that. But it's clear that there are still many struggling to access psychological therapies. I return to my earlier point. Patients can only enjoy a person-centred healthcare experience if the resources and staff are in place to deliver it. Good work's been done in improving the mental well-being of Scots, but there is still much to do, of course, not least in widening access to talking therapies. If we are to truly offer a person-centred health service, then I would have to agree with the Cabinet Secretary, for not once maybe, or twice, that the NHS must become a genuinely 7-day service. I welcomed his recent announcement that more had to be done to move away from variations of care at the weekend, and will take a keen interest in the efforts of the task force he has established to oversee these changes. However, the implementation of such a cultural change will regularly require a substantial more than £4 million investment the Cabinet Secretary announced last month. His press release did speak of ensuring pharmacists, physiotherapists and porters are on hand every day of the week, but I would gently remind him that consultants and registrars, of course, will also be vital cogs in a truly 7-day service, and I'm sure he's pretty well aware of that. The Minister, the Cabinet Secretary, I should say, I don't want to demote him, did mention in his intervention to myself that there are more positions now than previous with regarding consultants, but of course there is a large increase in the amount of vacancies, so I just wonder if the Minister would be able to, in his summing up, inform me if we are struggling to fill those vacancies. Presiding Officer, Lib Dems shall be supporting the Government's motion today, and we do see value in supporting the Labour Amendment 2, and hope that the rest of the Chamber shall support my amendment, a constructive amendment aimed at emphasising the importance of person-centred care, a motivated and appreciated workforce, and the work still needing to be done on mental health, its stigma, and that mental health is the basis, of course, as Bob Doris says, of good health care. Thank you.
Many thanks. Now Colin Jackson-Carlaw, 8 minutes or thereby, please.
Thank you, Deputy Presiding Officer. This afternoon's debate has been stuffed full of health debate season ticket holders, all welcome. But it has also been particularly nice, and may I say as well, to see one of our debenture ticket holders back in the chamber with us this afternoon, Richard Simpson. And it's been good to have him back. I feared a little bit when we started this afternoon that we were going to involve in the sort of ritualistic and tribal attacks on the health service in England and the coalition policies there. I've said previously in debates here that we hold no candle for what goes on in the health service in England. This is a devolved parliament, a devolved health service, and we accept and are quite happy to seek to make the health service in Scotland the best that it can, and understand that that is on the basis of the health service that is just now. But I think it would be churlish not to acknowledge that in England the coalition government has ring-fenced health service spending, which has produced consequentials, which have been available to the Scottish Government to spend as they see fit on the health priorities that they have here in Scotland. And I also thought, and I'd made mention of it, and I was grateful for Malcolm Chisholm's observation, that even while this Parliament does not want to follow the model of the health service in England, it would be churlish simply to say that every operational practice must be inferior elsewhere and that there is nothing that can be learned. That is the wrong approach, and I think it's important that where there are good practices, wherever they are, we are prepared to acknowledge and accept them. I want to talk about the contributions of various people in the debate and then make a few points of my own at the end, some of which I hope are new and others which will, of course, fall back on tried and tested views on this side of the chamber. I particularly want to comment on Nanette Milne's contribution. I think she made several well-informed points, and they were important ones too, particularly on the subject of GP practice and access, and the comments she made about the sustained lack of availability over holiday periods and some midweek availability as a result of training. She also talked about the way patients are dealt with in hospital. Now, I don't think, to say to Fiona MacLeod, she actually said in the 1950s. That would actually make Dr Milne in her mid-80s, and I think it would be ungallant to suggest, if not impossible, that that could be so. But yes, I think that also Malcolm Chisholm made the point that patients have to be talked to as persons and not things when they're in hospital. GPs do manage that interaction, I think, better than many of us who, when we found ourselves in hospital, have found us spoken to rather loudly and as if we are in some way incapable of understanding the normal English that's spoken to us. I don't know if Bob Doris is going to like this at all, but I actually found his contribution this afternoon one of the least blindly tribal that I've heard him make in all my years in Parliament, and I thoroughly enjoyed it. That may be to do for his future career. I thought Siobhan McMahon made a very pertinent point, and it was simply stated, is person-centred healthcare to become a politician's slogan rather than a patient's reality? And that is also always a fear, I think, in any of these initiatives, and one that we should keep very much in mind. There were characteristically loyal speeches from Aileen MacLeod, Richard Lyle and Jamie Hepburn, and some effective points as a result there too. And I very much enjoyed hearing from George Adam, who told us about Mrs Adam and multiple sclerosis, but I sat as a substitute in the committee that approved the establishment of an MS cross-party group in Parliament. And, of course, all members, I think, are concerned about the proliferation of such groups, but it was his personal commitment, which I think is well understood in the chamber to this issue, that very much persuaded members on the committee that day that this would be a very worthwhile addition to the Parliament firmament. I thought he was a little unfair in Mr Findlay. I thought in suggesting that he'd been criticising health service staff. Let me say of Mr Findlay, and I hope he takes this as a compliment because it's meant to be, but he has always reminded me as very much of the Eric Heffer tendency in the Labour Party. That is to say, solid, robust, socialist, uncharacteristically wrong about everything, of course, but with a bonhomie and an enthusiasm which I think is to be welcomed. But I fear I must.
Neil Findlay.
Being accused of being wrong on every point by the member is surely a badge of honour.
I'm happy that you should think so. We also heard from Mark MacDonald this afternoon, who is the celebrity amongst us, because I note with interest that he has been nominated as the one to watch by the Herald. I have to tell him I was nominated for that once and then lost to Shirley Ann Somerville, who then lost her seat. So I leave it to him to establish what the moral of that example is. Can I turn to a few points? The first, I want to talk about the GP access. I think we underestimate the public response to the way we have talked about accident and emergency departments being centres of excellence. Because we have all understood that the greater the range of specialisations that exist within an accident emergency department, the more success there is likely to be for the treatment of patients. But I think we've underestimated the fact that a lot of members of the public have registered this as cut out the middleman and go straight to A and E. And I think we've got to thereby ensure that people understand that GPs are there for a very particular purpose. And that is why I welcome what the Cabinet Secretary has said about making GPs more accessible. We've talked about the provision of walk-in centres in some of Scotland's cities as being a way forward. And I hope that's something that can happen. But it's interesting in England, where they've had walk-in centres, when patients have been asked where they would have gone to if they hadn't gone to the walk-in centre, 40% said straight to accident and emergency and only 20% to their GP. And I think we have got to ensure that through the online repeat prescriptions and availability of appointments, I think we've got to ensure that that is the case. And maybe our GPs would benefit from spending some contractual time in accident and emergency departments themselves, in order that patients are persuaded that in going to their GP, they are going to a local centre of excellence just as much as they feel that going to accident emergency is a centre of excellence too. This has been suggested by some down south, and I think it's an idea worth exploring. The other area I think that potentially we should be looking at is the growing issue of those who do not attend the appointments that are made for them. Now, underpinning all of that, I think, has to be an effective communication. My most recent visit to hospital, which was a couple of years ago when I was an inpatient and then had follow-up appointments afterwards, invariably I received notice of my appointment on the day it was taking place. As it happened, I wasn't doing anything else, so I was able to attend. But I don't think that's ideal, and therefore there will be those who are missing those appointments because some sort of slow mail process is being used to advise them of appointments. On the other hand, it's not helpful in our hospitals and in our GPs that there are people not able to get appointments because other appointments are booked by those who then find themselves well but not disposed to let anybody know that they no longer need the appointment and thereby free up the service. I've talked before about the Conservative view about a national universal health visiting service. I still believe that that is fundamentally of value in much of what we're discussing today because it's all about preventative care, which in the long run is how we reduce the burden on GPs and on hospitals. Presiding Officer, we will support the rather cheeky amendment from the Labour Party that was slipped in. We think it will be a challenge this winter, and I think all the health boards would do well to follow Lothian's example and be very candid about exactly where they think the pressure points are going to be. Better to know that now than to find out in a distressed situation. And we will support Mr Hume's amendment and the Government motion this afternoon.
Many thanks. I now call on Rhoda Grant. Up to 11 minutes, please, or thereby.
Thank you, Presiding Officer. And can I also start by welcoming Richard Simpson back into the Chamber? Can I say, for those of us on his emailing list, he's not really been away. He barely paused, and I remember opening an email quite late one night, I think sent from intensive care, that started, "They've given me my iPhone back," and they continued ever since making points about policy and what we should be doing. So I very much welcome those emails and welcome him back to the Chamber. Can I also say that I welcome the opportunity to debate person-centred care, and I think it's something in a way that we can all unite around because it's crucial that it's there. But many speakers made the point that we can't do that without resources and time. Malcolm amplified our amendment, which commends those delivering health and community care, and very often in very difficult conditions. If we're going to deliver person-centred care, then it must be delivered with the proper tools, such as beds and blankets and pillows. Neil Findlay talked about last winter and the case of John McGarity, which was really striking. But if I can just quote a senior staff nurse speaking around the same time, And she or he, I'm not very sure which, but said it is completely normal and a commonplace occurrence to have old people and very ill people lined up in corridors and trolleys because there's not enough beds. In some cases, they are the lucky ones. Others don't make it out of the waiting room because there are no trolleys or indeed staff to put them on. And that is a real concern when we're sitting with 1,000 less beds and 1,200 less nurses than September 2009. And we have listened to the concerns that people have brought to us, that they fear that the system will fail again this winter. And our amendment, therefore, asks the Scottish Government to agree that waiting times will be met over the winter months. And by doing that, they can offer reassurance that they have made sure that the same will not happen again, that they have learnt the lessons from last year, they have assessed the pressure points, and they have put steps in place that make sure that this won't happen. If they can't give that guarantee, either the Minister in winding up or how they vote tonight will show that indeed the concerns that are being amplified to us are very real. And if that's the case, they need to act now to make sure we're not back in the same place. Others talked about the RCN's submission on the back of this debate, and they talked about the very special pressures over the winter period. But they've said that staff are already overstretched as vacancy rates increase and we use more and more bank nurses. The use continues to go up. And I think it was Jim Hume that quoted them on that. But Nanette Milne talked as well about how people need to be involved and how people need to speak about making decisions so that they can be at the centre of that. But if we don't have enough staff, and indeed if we're reliant on bank staff who come and go, who are a transient workforce, then how can we actually listen to people? And how can we recruit people to those jobs if we don't have their pay and conditions right? And it is quite sad that senior managements and managers and NHS boards are getting a 4% pay increase, where the nurses delivering that very service are only getting 1%. And I think we need to... I will take an intervention on that.
Cabinet Secretary Alex Neil.
I thank the member for taking an intervention. I think the member and indeed Mr Findlay are totally misinformed about this increase. And I'm happy to send them the details because they keep repeating something that's just not true.
Rhoda Grant.
I'm disappointed he didn't take the opportunity to tell us and maybe put on record what the actual truth is, but that is the truth as we understand it. And it would be nice to see that all health service workers be treated the same and indeed have their work appreciated by ensuring that their standard of living doesn't fall. Can I turn to self-directed support, because I think a lot of people mentioned this as part of a person-centred approach. Siobhan McMahon talked about Pam Duncan, and I think those of us who have met Pam just realise how tough she is. And if she was experiencing real difficulty in applying, then surely everybody else is going to be put off by that process. So I would ask that the Minister maybe relook at the process to make sure that people are not being put off applying. I recently attended a Spain conference, and they're an organisation that actually work with users and carers indeed, and help them take hold of their own budgets, employ their own carers, and take control of their own experience in their own hands. And I was really impressed by what they were doing. But I was also quite shocked by some of the things they said in the conference. And I think one of the people that was there making a presentation was Tommy Whitelaw, and anyone who's met or heard Tommy speak can't help but be moved by his experience. And I think he's doing a number of sessions, I think, called Tommy on Tour. If he's coming to an area near you, can I just suggest you go and listen to him? He talked about his experience in looking after his mother who had Alzheimer's, how difficult that was, how she became a non-person to a lot of those who were providing service, and how difficult he found the whole experience, and became very, very isolated during that part where he should have actually been supported. So we need to listen to the experience of people who actually use the care services and make sure that they are heard and that they lead change in how we deal with those issues. Bob Doris talked about council cuts, and this is obviously a time of real concern for people who are dependent on services. While the health service budgets have been ring-fenced, councils have faced real cuts in their budgets. There's a an unfunded council tax freeze, and the Scottish Government is responsible for that. They can't complain about councils making cuts if they're not giving them the resources to provide the service. They are at the front line of prevention, they're at the front line of preventative health care, and therefore we need to make sure that they have the resources to do that. Otherwise, those costs fall back on the health service because they have to pick up the fallout from those cuts. And I'll take Bob Doris.
Doris.
I thank the member for that. I won't get into a political debate about cuts to local authorities, but just specifically in relation to Glasgow, because I did refer to that. There are no cuts within the social work budget in Glasgow in relation to adults with learning difficulties. It's a political choice being made not to support self-directed support in Glasgow, and I just want to put that in the record. It's not because of cuts, it's a political choice that's been made.
Duncan McNeill shouting behind me, all cuts are a political choice, and indeed it's a political choice of this government not to fund the council tax freeze that are leading to some of those very, very difficult decisions being made, not only in Glasgow but in councils all over. And listen to councillors saying that this is not what they got into politics for, and they're delivering very, very difficult decisions. Duncan McNeill talked about personalised care, and I think that's a step further, but I think it's something we should pursue, that care starts, the person is not centred to the care, but the care package starts with the very person at the core. We need to look also at the financial pressures. While we've been told that health budgets are ring-fenced, the Auditor-General has put health boards on amber warning. And I think that's because some of the pressures that are coming from other areas, such as local government, where people are coming in as unplanned admissions into A&E, and there is no way of taking them back out of hospital because the resources are not there in the community. A number of people spoke about procurement, and I think this is vitally important, because if we don't get the services in the community right, how can we put people at the centre of it? How can a 15-minute visit actually achieve anything at all? And I don't know if anyone watched a programme, I can't even tell you what the programme was, but it just caught my attention. There was an elderly lady and her husband who both got a 15-minute care visit. And the carer was saying that she couldn't deliver the care they required. And she said sometimes she thought that those clients were afraid to ask her to take them to the toilet because time was so short. I mean, that is the very basics of care, and we need to have that in place. We can't do that through paying the minimum wage, through 15-minute care visits and indeed untrained people working in those services. We need to value all those who are delivering those services. And this is just going to get worse, because there is a demographic time bomb coming. We need to make sure that the funding is there. We need to make sure it is fair. For instance, is it fair that people who suffer for Alzheimer's have to pay for their own care, while people who have cancer get that care funded? And those are things within our system that we need to look at. We also need to make sure that people have access to palliative care. We listened to Mary Curie talk about those with cancer having access to palliative care, but others with other conditions not having the same level of access. So those are all things that are coming that we need to talk about. And indeed, Mary Curie, I think, brought to our attention a number of issues. One, the patient, the bereavement survey, which I think would be helpful to learn from what people were saying, but also about the out-of-hours multi-patient service that is happening in NHS Fries and Galloway, which to me seems like an excellent initiative to keep people out of hospital but give them the care they require at home. You wouldn't believe it, Presiding Officer, but there are many other things I could say, even with the additional time that you have allotted me. But maybe I could just finish by saying person-centred care is really important, and I think we all agree that it is essential. And we want it to work for all, not 90%, not 96%. We want it to actually work for everybody. But to deliver it, we need to value the staff that are delivering it and give them the tools to do so. They need time, and they need resources, and they need planning. And we need the Scottish Government to make sure those tools are in place so that they can provide more than warm words.
Many thanks. And I now call on Minister Michael Matheson to wind up the debate on behalf of the Government. Minister, you have until 5 o'clock, which will essentially be 11 minutes and 10 seconds.
Thank you, Presiding Officer. I've listened with real interest to many of the contributions here this afternoon, and Duncan McNeill in his contribution invited us to have a nice start around this whole debate around person-centred care, that we come to an agreement around what the definition of person-centred care is. And we've obviously set out in our strategy what we believe is the definition of person-centred care. But I do think it has been a debate where we have explored issues around person-centred care. And if there is anything that we can agree on, I think this is a debate where there is more in agreement than there is divides us in this particular agenda and how we take forward person-centred care. I think all members also recognise that the status quo is not an option. The present environment in which we have to take the change forward makes it more challenging, but that we all recognise that even if we were still in the land of milk and honey, there would still have to be change in the way in which we deliver services. And as the Cabinet Secretary set out in his opening remarks, all of this change has to take place against the backdrop of those three big challenges which we face within our health and social care system in Scotland. The financial challenges which have been forced upon us, that find us in the present financial situation that we are in, and changes have to be managed within that financial envelope. The inequalities which we continue to have within our society, and Scotland's own health inequalities are very marked. Historically, we've always looked upon health inequalities as trying to seek and trying to identify a health service solution to addressing these inequalities. The reality is that health inequalities are the symptoms of the wider inequalities which we have within our society: income inequality, social inequality, educational inequality, attainment inequality. And if we are going to address health inequalities, we have to look at what the root causes of those inequalities are much more effectively in order to achieve that. And to do that effectively, you have to have a system that is able to do that in a combined way and in a systematic way over a period of time. But alongside that, the third challenge that the Cabinet Secretary set out was that of the demographic shift that is taking place within our country, as is the case with most other countries across the world, and the challenges that creates with people living longer and living longer with different health conditions, and the need to make sure that we have a health and social care system that's configured in a way that allows us to effectively meet those care needs in a person-centred way, and to support individuals to live as long a healthier life within their own home or within a homely setting. Now, in bringing this debate forward today, very often when we have health service debates in this chamber, it largely focuses on the acute secondary care setting. And the brickbat goes between what should happen in different departments within our acute sector. And that's why we specifically brought forward this debate on primary care, to give a focus to that in a way which we don't believe is often reflected in debates that take place around our healthcare system. But what I think it's important to recognise is that the primary care system is an important part of the overall system in itself, between secondary care and also the social care system. And it's about integrating that in the most effective way that allows us to provide that person-centred care to individual patients in the way that I think we all recognise that increasingly, as Duncan McNeill made in his own contribution, increasingly patients expect to see and to receive in the way in which their care is delivered. Now, I, like everybody else, recognise that delivering person-centred care is not something that's just going to happen at the drop of the hat, off the back of one single strategy that says that's what we want to do. There are challenges in taking this forward. There are challenges because of the way in which the system is configured. There are interprofessional challenges in taking it forward. There are cultural shifts that have to take place in order to do it, none of which I don't think are insurmountable. But what we have to do is be committed in recognising that's the vision that we have set for our health and social care system, and the measures that we then take in order to help to take that forward. Can I also say that in the course of the debate, a number of members have made reference to individual cases. Neil Findlay made reference to an individual case, as a few others did. I, like everybody else, get constituents at my surgeries who come along who are dissatisfied with the way in which the NHS is performed. I've witnessed it personally not get it right. But what I do know is that our NHS gets it right more than it gets it wrong. And we should always keep that in mind when we are discussing these types of issues. What we should not do is use individual examples and then suggest as though the whole system in some way is falling apart or is not working effectively, because that does a disservice to the thousands of staff within our NHS who are dedicated to their job and who work day in, day out to deliver the best possible care for their patients, for which we are grateful as a country. I'll give way to Mr Findlay.
Neil Findlay.
What we should also not have is a debate that skates over some of the real issues that people are coming to us on a day-to-day basis.
Well, that was a really helpful comment. You know, you would give the impression as though the Cabinet Secretary and I, in some way, live in some type of ivory tower and think everything is perfect. We have brought forward a debate today to debate how we can improve the system because we know it's not good enough. Nobody's trying to skate by and kid on that there are not problems in the system, but we also have to be realistic about how we go about dealing with these challenges within our system, rather than just throwing away comments that don't really offer anything to the whole debate about how we improve the system overall. Can I also say that when it's about trying to address these types of issues, it's absolutely key that we learn from the mistakes that do occur within the system when we get it wrong. When the NHS doesn't work as well as it could, we'll learn from that. And as Malcolm Chisholm said in his own contribution, Jamie Hepburn made in his contribution, we need to make sure that we listen to that patient experience and that we use that as a way of allowing us to build upon making sure that we don't make those errors again in the future. But despite the positive, can you just let me make a bit of progress on this point? But despite the fact that patient satisfaction levels in Scotland have been improving and continue to be at a very high level, that's not to suggest that we are complacent in any way. I want our health service to get it 100% right every single time for every patient. But I recognise, as Mark MacDonald said, sometimes that will not happen. What we need to do is to make sure that we learn from that experience and we use that experience when it goes wrong to make sure it doesn't happen again. And I'll give way to Rhoda Grant.
Rhoda Grant.
I'm grateful the Minister is keen to learn from experience. Can he tell us whether the Government have learned from the experience of last winter when many people weren't able to get access to beds in hospitals? And can you guarantee that that won't happen again this year?
Michael Matheson.
I'm going to come to the issue around accident emergency departments in particular, given they were raised in the course of the debate. But yes, as soon as the winter period is over, our NHS boards move into a process of planning for the forthcoming winter, and they learn from their experience of the previous years in order to assist them in doing that. And one of the things that Richard Simpson raised, and it is good to see Richard back because he always makes a very substantial contribution to health debates in this Parliament and is duly respected for that. Richard Simpson made the point around the issue of learning from the complaints process and the patient experience process which is taking place as a result of the Patients' Rights Act. What I can announce today is that I've asked the Scottish Health Council to do an analysis of the first round of reports from all of our NHS boards as part of that feedback and complaints process which were produced in September of this year, and for that analysis to be completed by the spring of next year so that we can see the areas of good practice where there's learning it can be built upon so that we can use that type of information much more effectively across all of our boards. And I'm no doubt that Richard Simpson will look forward to seeing that report from the Health Council when they publish it in the spring. Can I turn to the issue of accident emergency departments? And of course, the pressures which our accident emergency departments in Scotland faced last winter were no different from that across the rest of the UK. There's a variety of reasons for that. Part of it's like the point that Jackson Carlaw highlighted, that there are tendencies at times for some individuals, rather than to make use of primary care services, to go straight to accident emergency departments. There are also just demands in terms of the weather and flu and whatnot, which can have an impact on the system. But one of the measures that Rhoda Grant asks is, have we learned from it? One of the things we have done since last winter is provide £50 million for an unscheduled care programme. Each of our boards have been commissioned to take forward localised unscheduled care plan programmes in order to look at what they need in the way of staffing and other resources in order to assist them in making sure that they are able to meet the demands that they will face undoubtedly this winter. And in doing that, they've made very significant progress. Jim Hume raised questions about the recruitment of staff. So far, there have been 13 of the A&E consultants have been recruited, and some 39 nurses have been recruited as well. But the whole issue about the extra recruitment for this year alone has got to be kept in the context of what's happened over recent years. So since 2006, the number of A&E consultants within our health service here in Scotland has increased by over 100%. We have doubled them. By the additional 18 that we're paying for this year as well, we will take it up to almost 110% of an increase since 2006. Now, that demonstrates the level of resource that we are putting in to make sure that we try to support our A&E departments to meet the demands that they will face this winter much more effectively. And when Margaret McCulloch was talking about the challenges which our A&E departments face, including in places like Lanarkshire, she seems to forget that it wasn't the SNP government that proposed to close the Monklands A&E department. It was the last Labour Lib Dem administration that proposed to do that. And she may be interested to know that up until June this year, the A&E department at Monklands had dealt with 67,000 attendees. Could you imagine the state we would be in if we had listened to the last Labour Lib Dem executive and actually closed that department? The pressure would be even greater on A&E departments across the country. So that's the type of practical measures that we have taken in order to try and address some of these issues. But in drawing my remarks to a close, Presiding Officer, can I say that as a government we are very much committed to making sure that we build on the good progress we've made over the last 6 years in our NHS. We are happy to accept the 2 amendments that have been put before this chamber here today. And I can give this chamber a clear guarantee that we will protect the NHS and do all that we can to support our NHS boards and our partners over the winter to make sure that they meet the needs of the patients of Scotland during the winter months here in Scotland.
Many thanks. And that concludes the debate on person-centred healthcare, and it's now time to move on to the next item of business, which is decision time. And there are 3 questions to be put as a result of today's business. And the first question is that Amendment 8155 .1 in the name of Neil Findlay, which seeks to amend motion number 8155 in the name of Alex Neil on person-centred healthcare, be agreed to. Are we all agreed? Yes. We are. The next question is that Amendment 8155.2 in the name of Jim Hume, which seeks to amend motion number 8155 in the name of Alex Neil on person-centred healthcare, be agreed to. Are we all agreed? Yes. We are. The third question is that motion 8155 in the name of Alex Neil as amended on person-centred healthcare be agreed to. Are we all agreed? Yes. We are. Thank you very much. And that concludes the decision time, and we will now move on to the next item of business, which is members' business. And I invite members to leave the chamber quickly and quietly. Thank you.